committee will come to order. Thank you all for joining us today. Thank you, Secretary Becerra. This hearing provides an opportunity to examine the policy proposals outlined in President Biden's fiscal year 2025 budget request for the Department of Health and Human Services. HHS is an incredibly important agency responsible for running Medicare and many of our health programs and critical in responding to unexpected events such as the recent cyber attack of Change Healthcare. But today, we seek your commitment to leverage your resources to ensure patients and providers have access to timely care. Turning to the budget request, I have serious concerns that these policies continue to prioritize politics over the health of the American people and will harm access to quality, affordable health care. The Biden administration's continued pursuit of a harmful agenda, combined with your department's failure to address its own shortcomings, has required this committee to take action on multiple occasions to force your hand. All across the country, in districts like mine, rural and underserved patients struggle with access to care, which has been worsened by hospital closures and provider shortages in recent years. One-size-fits-all mandates, such as the proposed rule regarding nursing home staffing that was rejected by this committee, will further fuel that crisis and result in the closure of more facilities. You failed to follow congressional intent when implementing healthcare policies like the bipartisan surprise medical billing protections. During Ways and Means Committee hearings this past year, and as recent as Monday down in Denton, Texas, we have heard consistently how this has resulted in less access and reduced in-network affordable care for patients. You neglected to hold hospitals accountable for non-compliance with price transparency requirements until this committee and Congress placed intense pressure on you to do so. Earlier this year, the House of Representatives stood up for patients again in a bipartisan manner and passed the Lower Cost, More Transparency Act to enshrine these requirements into law. I hope this action signals to your department how important price transparency is to the American people and will guide your decisions going forward. The budget also doubles down on the Biden administration's scheme to expand Washington price controls on drugs. We heard from witnesses at hearings last summer that these price controls will decimate critical research into diseases like cancer and Alzheimer's, depriving patients of life-saving treatments and killing up to 1.2 million jobs in the United States. Equally troubling is the allocation of $272 billion in new Obamacare subsidies to wealthy households making nearly $600,000 per year. Our Health Subcommittee's first hearing this Congress examined the high cost of health care driven by Obamacare's mandates, and I'm disappointed to see the budget propose bailouts to private health insurance companies as their only solution. In January, the House was forced to pass legislation from this committee blocking a misguided HHS rule to eliminate funding for pregnancy resource centers, which play a vital role in supporting maternal health and prenatal care. Again, this does not line up with the administration's stated goal of improving access to care. You claim to support a woman's right to choose their own health care, but then you make it harder for moms to choose life for their unborn child. Recent reports also indicate the crisis at our southern border and the staggering influx of illegal immigrants has placed strain on an already overburdened foster care system, as well as access to care for U.S. patients at vital safety net hospitals. We are eager to hear your plan to address the impact of the border crisis on these services because your budget suggests there is not one. Words like diversity, discrimination, racial justice, and gender all appear in your budget far more than the border. Fentanyl, the #1 killer of Americans aged 18 to 45, is mentioned only once in a footnote in the budget. I hope recent committee activity has made clear to you that we are demanding accountability and transparency at your department, as well as solutions that will actually improve the health and well-being of the American people. It is imperative that healthcare policy prioritize patient outcomes over political agendas. particularly in the face of urgent public health crisis. Thank you again for being here today, Secretary Becerra, and I look forward to discussing these important issues, and I'm pleased to recognize Ranking Member Neal for his opening statement.
Thank you, Chairman. It's always a pleasure to welcome back one of our own alums, and we're delighted to have Secretary Becerra before this storied committee today. Appreciate you being here, Mr. Secretary. Democrats have transformed our nation by prioritizing the well-being and wallets of the American people, rebuilding our economy from the bottom up and the middle out, and the results are indeed record-breaking. 15 million jobs created under President Biden, back-to-back record-breaking open enrollments and strides in finally holding many of our drug companies accountable. Truly an unbelievable transformation between now and indeed your first budget hearing, Mr. Chairman. The timing of this meeting is especially sweet since later this week we will celebrate the 14th anniversary of the Affordable Care Act. Back then on this very dais, we moved with the dream of what could be, and thanks to the investments and commitment from the Biden administration, the ACA is alive, strong, and quite well. More Americans have health coverage than ever before, with 21.3 million Americans signing up for the last open enrollment. 4 out of 5 Americans can access high-quality plans for less than $10 per month. Seniors are saving on their out-of-pocket costs, which will be capped at $2,000 per year starting next year. They are also saving on insulin, which we capped at $35 a month, and I look forward to bringing this savings to the American family at large. The ACA is now firmly the law of the land. It's polling quite well, standing proudly as a beacon of what's possible when government does what's best for its people. Our nation's teenagers don't even know what life is without the ACA. We've taken away the fear of the insurance company discriminating against those with pre-existing conditions. Even women are cutting off coverage or being denied coverage due to cost. For 14 years, the American people have had peace of mind and the only path forward, never once backward. While accomplishments have been superb, President Biden's budget shows what we can build through this progress and how we might finish the job for the American family. Ways and Means Democrats share the view that when we invest in our health and caregiving, we are investing in the nation's children, families, and the economy of tomorrow. From the Affordable Care Act to the expanding Medicare's power to lower drug prices to permanently extending this committee's premium tax credits, we are putting the needs of the American people first and taking our cues from them. 96% of Americans agree that lowering drug prices is an important way to help people afford the cost of living. Another reason we intend to continue to expand these savings. All while our progress has never been more popular, our colleagues on the other side have not demonstrated many plans of their own, and they unite around what they don't like about ours. Recently, the former president said, as he reignited attacks on not only the Affordable Care Act, but also on Medicare, 2 wildly popular programs that the American family depend on. Uprooting settled popular laws of the land, including the ACA and the Inflation Reduction Act, which was a superb piece of work that came right from this committee, will send our nation backwards while all putting lives and livelihoods at risk. We are delighted, Mr. Secretary, that you are with us today. It's a privilege to share this progress with you, as I'm sure you will remind all of us in the coming minutes. Nice to have you here, Mr. Secretary.
Thank you, Ranking Member Neal. Today's sole witness is Department of Health and Human Services Secretary Becerra. The committee has received your written statement, and it will be made part of the formal hearing record. Secretary Becerra, you may begin when you are ready.
Chairman Smith, Ranking Member Neal, and members of the committee, great to be with you again. Thank you for giving me an opportunity to speak about the President's FY 2025 budget for the Department of Health and Human Services. We could go back to January 2021, when President Biden first took office. If you recall, COVID was ravaging our families and our economy, and Americans were dying at the rate of 2 to 3 9/11s every day. Let me repeat that again. Every single day, not one 9/11, not just 2, but oftentimes 3 9/11s were occurring every day in America as we were losing so many of our loved ones. When President Biden took office in January 2021, COVID was not just hurting our economy, it was hurting the way we did business. In January 2021, the number of Americans with health insurance was, like our jobs and our economy, down and on the canvas. In January 2021, prescription drug prices were skyrocketing, with patients and their pocketbooks at the mercy of Big Pharma and its profits. Today, 3 years later, nearly 700 million shots of COVID vaccines have gone into the arms of Americans, and we can now manage COVID like the flu. Today, more than 300 million Americans, a record number, can go to the doctor or hospital and not go bankrupt because they have their own health insurance. More than 21 million of those Americans count on the Affordable Care Act marketplace for their insurance, another record. Today, while Big Pharma, well, they're still big, the President's new prescription drug law has brought down the price of insulin to $35 per month for Americans with Medicare. And as we speak, we are negotiating with drug companies to lower the prices of even more prescription drugs, even as they sue us to stop us. The President's budget doubles down on the investments that made the comeback of our jobs, our economy, and our health possible. It lays out a vision for a nation that invests in its most vulnerable, fosters innovation, and protects every American's access to the care that she needs. This budget doesn't just strengthen Medicare, it strengthens it beyond our lifetime. This budget continues our shift from a health system that treats illness to one that sustains wellness. All told, the FY 2025 budget proposes $130.7 billion in discretionary and $1.7 trillion in mandatory funding to advance our mission and invest in key priorities. Let me share a few of the highlights. The budget provides Medicaid-like coverage to low-income individuals in the outlier states that have not expanded Medicaid under the Affordable Care Act. When that happens, another 1.5 million Americans will have health insurance coverage and the peace of mind that comes with it. This budget builds on the largest investment in behavioral health in a generation. It bolsters the 988 Suicide and Crisis Lifeline. It gives young people support at home and at school. That means boosting our behavioral health workforce with 12,000 new psychiatrists, psychologists, clinical social workers, marriage and family therapists, counselors, and peer support specialists. Across HHS, the budget tackles the maternal health crisis by improving access to pre- and postnatal care, supporting emergency care services, and expanding maternal care in rural and underserved communities. We are making childcare more affordable for working families and more available where families actually live and work. This budget would provide increased wages for early childhood education workers, and it would fund more than 750,000 slots for children in Head Start. And it funds universal preschool for our nation's 4 million four-year-old children. And eventually, it would include our 3-year-olds as well. Our budget grows and strengthens our cybersecurity initiatives to ensure patient safety and privacy, and to keep our hospitals and providers, especially our smaller ones and those in rural communities, running and secure. Finally, this administration has made tremendous strides in preparedness capabilities since the pandemic, and we keep building. This budget invests in countermeasures to combat antimicrobial-resistant drugs, expands our monitoring of supply chains, and integrates 200 data sources across federal, state, and local governments to improve information sharing. We can't reduce the health and well-being of Americans to a line on a budget spreadsheet, but we can transform the number on the balance sheet into investments and services that sustain health and promote wellness for all Americans. President Biden has presented a forward-leaning budget. I look forward to taking your questions. Thank you.
Thank you. We'll now proceed to the question and answer session. On February 29th, every Republican member of this committee sent you a letter asking what your department is doing to address the impact of the illegal immigrant crisis on our healthcare system. This influx of illegal immigrants has forced safety net hospitals like Denver Health in Colorado to turn away patients and reduce the number of beds reserved for Denver residents seeking substance use disorder and mental health treatments. What is your department doing to address this growing crisis, given the real fear that other hospitals in sanctuary cities across the country may similarly be impacted, harming the nation's healthcare system, safety net, and threatening healthcare access for vulnerable patients?
Mr. Chairman, thank you for the question. As you know, we have some of the most advanced and capable hospitals in the world. We count on them to be able to keep Americans healthy and safe. We continue to work with them day in, day out. When Change Healthcare had this cyber attack, we were there to support them as well. We will do everything we can to make sure they continue to provide the services that Americans count on, whether it was during COVID or whether it is now. We're prepared to work with every one of our hospital facilities to make sure that they continue to operate and provide the services that Americans count on.
Has your department been working with Denver Health in Colorado with the issues that I just raised?
We've certainly been working with the state of Colorado, and if we were to get a particular request from a particular facility, we would certainly then try to work with them to resolve any issues they might have.
Earlier this month, the committee passed legislation introduced by Representative Fischbach to block the implementation of the unworkable one-size-fits-all nursing home staffing mandate. Estimates show this rule will impose a $40.6 billion cost on nursing homes, 94% of which currently wouldn't be in compliance, jeopardizing access to care for 1.2 million Americans. Can you commit to the Medicare beneficiaries watching this hearing that no nursing home will close and patients won't lose access to care as a result of this rule?
Mr. Chairman, I can commit to you, and I commit to each and every one of the Medicare beneficiaries that is out there, that if they need a nursing home, they will find one that offers them quality care. We want to make sure that no nursing home becomes a death sentence for any American who has to use the facility. And we want to work with every nursing home to make sure that they are offering quality services. And if you think about it, of the 1,200,000 or so Americans, 1,500,000 Americans who reside in nursing homes, that is a fraction, a little bit more than 1% of, not even 1% of the population. But when you take a look at the death numbers that occurred during COVID, and you realize that 1 of every 5 Americans who died from COVID died in a nursing home, something's going on. And we can't just close our eyes to it. We have to make sure that if we're going to leave our loved one in a nursing home, there is a nurse that's available to provide care. And these standards simply say that. Make sure that if you're going to claim that you're a nursing home, you have the professionals who can provide the services to our loved ones before we leave them there in your care.
So San Francisco recently enacted a law requiring residents who are suspected of using illegal drugs to undergo treatment as a condition to receive welfare benefits. Since 2011, my home state of Missouri has required certain TANF recipients to be screened for illegal drug use, a law that I helped advance at the time as a member of the State General Assembly. And as it relates to the rise in opioid abuse, you yourself have said all options should be on the table when it comes to how communities across the country address the drug crisis. Given that TANF has an outright ban on providing assistance to those with drug-related felony convictions, I appreciate your position, which many of us have believed for a long time, that states should be looking at how to utilize drug testing in their welfare programs. If San Francisco's actions are suitable, then surely other cities, counties, and states should be encouraged to make similar decisions. And so to that end, and consistent with your recent comments, is it fair to say you are open to Congress and states putting stronger protections in place to make sure recipients of welfare benefits are being screened or tested for drug use?
Chairman, thank you for the question. I want to make sure, please do not misinterpret what I said when I referenced the drug crisis, the overdose crisis that we face in this country. Certainly, we want to make sure we are exploring every opportunity to save a life when it comes to the overdose crisis that we face. What decisions a local community decides to make for itself and how it will handle TANF dollars, which is different from specifically dealing with the overdose crisis. I won't pass judgment there. I don't represent that area. I don't have jurisdiction on those issues. But what I will tell you is that any community, whether it is San Francisco or whether it is your district, Mr. Chairman, we are ready at HHS to try to help address the overdose crisis, because no American should die simply because of fentanyl and these other drugs that are now infecting our communities.
Thank you, Secretary. I now recognize the ranking member for any questions he might have.
Thank you, Chairman. Before I get to cybersecurity, Mr. Secretary, I want to remind all that the success that we've had with open enrollment at the ACA has been stunning. I think that's a fair term. But also the consequence of what happened in this very room 14 years ago. And you consider, as we sit here today, every child in Massachusetts has health insurance. 97% of the adults in Massachusetts have health insurance. And it polls in the high 60 percentile in terms of satisfaction. So I think that we should not forget the success that we had. Nationwide, it's polling in the low to mid 60s, yes. And the enrollment process continues, and we are indeed grateful for the work that took place here. But let me talk about cyber attacks on the healthcare infrastructure that you're quite familiar with. Hospitals and healthcare providers are facing increasingly frequent and sophisticated threats, even when they're not directly targeted. The recent cyber attack on Change Healthcare and the resulting fallout demonstrates the potential consequences we face if we do not take appropriate measures to protect and secure our data and the systems. Talk about what HHS has done to support the healthcare system in light of what we've learned at Change Healthcare and the attack over the last few weeks.
Thank you, Congressman. Since we first learned of the attack on February 21st, we have been in near constant communication with not just United Health Group, but with most of the stakeholders, especially the insurers, who are the payers for most of the bills that providers submit. We stood up our preparedness operations to try to be as available to providers as possible. To date, we have, I believe, issued some $2.5 billion in payments in advance, and I want to make sure that's clear. We haven't received the bill, but we provided $2.5 billion in payments because we know that these providers typically will bill us a certain amount every month or have a certain number of patients where they will bill us for Medicare or Medicaid. So we have made an arrangement so they can bill us in advance, and we will reconcile the differences later, but we want to keep them afloat so they can make their payroll. That means that some nearly 6,000 providers today have already received, as a result of Medicare or Medicaid's actions, payments, even though the bills have not come through the door. And we're going to continue to do that, and now we're insisting that the insurance companies that have, by the way, received money from the federal government under Medicare and Medicaid, that they also do the same and make it available to those providers.
Thank you. I'm going to give you a chance to talk, Mr. Secretary, rather than just dominating the time. So talk about the steps that CMS is taking to support the long-term care workforce and to increase oversight of those who operated outside the rules, which we painfully learned during the COVID crisis. And you've got a couple of minutes to talk about it.
Congressman, thank you for that. One of the biggest depressions that we faced in America with COVID was the loss of a workforce that cares for Americans, whether it's child care, whether it's long-term care, whether it's nursing homes. So many of those workers have never returned, many because they died, many because they just found something else, or they found that it was too dangerous to do the work. We are now trying to make sure that we help the various sectors bring up the workforce. And so we have made several $100 million in investments to try to support the training and the development of a more broad workforce, and we're focusing quite a bit of that investment on the behavioral workforce side. And so we continue to try to make sure that if you're going to go into the business of care, it pays you more than going to flip burgers at the local fast food joint. And it's tough, but that's what we have to do. We want to professionalize the service of caregiving in America.
Thank you. Thanks, Mr. Chairman.
Mr. Buchanan is recognized.
Thank you, Mr. Chairman. Thank you, Mr. Secretary. And I appreciate the time you made available to me on a couple of different occasions, working on different issues. I do want to touch back on the cyber attack. They claim $1 billion a day. How much of that falls kind of what created that scenario? Is it more industry, government, or what happened that we're in that situation? Because we're talking about a lot of people being put in the street, a lot of industries, businesses that might have to close. It's a big issue, and we need to learn from this to make sure, ideally, it doesn't happen again.
Congressman, thanks for the question. Consolidation, if it means efficiency, can be a good thing, but consolidation, if it means you rely too much on one big player, can be very dangerous. United Health, the owner of Optum, the organization, the company that essentially does billing for about a third or a half of the entire healthcare sector, that provides medical data back and forth electronically, When it got attacked through this cyber attack, it went down. And when it went down, it took pretty much all those providers who depend on them to be able to pay their payroll, to do their billing. The result was essentially a bit of a crash in the industry. What we have to do is recognize that if one player is going to be so big, they have to have the fail-safe option if something happens to them. Very similar to what happened with the infant formula situation, where a big manufacturer of infant formula went down. All of a sudden, the rest of the manufacturers weren't ready to cover for the loss of that manufacturer's supply. We can't allow the private sector to run its operations as if it's not going to face some of these cyber attacks.
Yeah, let me ask you this, and when we were at your office, we talked about my big passion is trying to work in terms of preventative care. We're spending $4.4 trillion, but yet we spend less than 3% on preventative care. So in other words, I don't want people to get cancer in the first place. I don't want people ideally to get a heart attack in the first place, might not see the next day. What more can we be doing? And the other thought is type 2 diabetics. It's off the charts. So I read the other day, someone said, you got to be the CEO of your own health. I realize not everybody's going to do that or want to do it for whatever reason, but I think there are a lot of people that want to be more knowledgeable, more educated. And a lot of the food, I hate to say it, not all of it, but a lot of it's junk food. So it's not all on them. You know, they think they're eating food, but it's highly processed food. There's not much quality to it in terms of food value. But what's your thoughts on what we can do? I think government has a role in trying to educate people where they, you know, a little better diet, little exercise 2 miles a day, 5 days a week, so they take some of the responsibility on themselves.
Congressman, we're with you on this. As I said in my opening remarks, we want to shift the system of healthcare from one that treats illness when you're already at that stage where whatever happened, it wasn't good, now you're having to treat it, to one where we sustain wellness, keep you healthy, as you said. So we're very much into moving towards what we call food as medicine. So we treat food as medicine. It's better than popping a whole lot of pills. How about if you put fresh fruits and vegetables, nuts and berries in the diet of your kids? We're also very much in favor of things that are very low cost but highly effective. Cancer screening. During the COVID pandemic, about 9 million people missed their cancer screenings. That means they probably found themselves, when they did go into the doctor, sicker with cancer than they could have been. We want to go back to the day of screening.
I only got a minute, so that's what I mean by prevention. Like lung cancer and stuff, one of the highest killers, and people aren't getting screenings. If you got a physical once a year in January, it'd make a big difference, headed off at the pass. The other thing I just want to talk just quickly on is the whole thing on telehealth. I'm in a very senior area, fifth oldest district. It's really critical to them. There's some discussion. Obviously, the extenders expire at the end of the year. Where are you at on that in terms? I think it's the future. You know, for a lot of these seniors are 80. I see it, 85. A lot of them are in pretty good health, but they might have to drive an hour, 2 hours a day to get where they've got to go, and this would be a lot better for them. And that, maybe not on the initial visit, after a couple of visits. Your thoughts?
We're with you. We can't allow those flexibilities to expire, and we need to work closer with our state partners, because much of the flexibility that comes from telehealth means that being able to go over state lines. And right now, because states decide who gets licensed to do care, we have to have the cooperation of the states so we can make sure that telehealth can go beyond its own state borders.
Thank you, Secretary.
Mr. Thompson is recognized.
Thank you, Mr. Chairman. Mr. Secretary, thank you for being here. It's good to see you back into your old home.
I'd be sitting right next to you, I think, if we're still here.
Actually, I kind of like it where I'm sitting closer to the middle. I appreciate the points that you made in your testimony about mental and behavioral health, especially among young people. It's something that I'm extremely concerned about, and I'm glad the department continues to take proactive steps in this regard. But I'm going to repeat something today that I said the same time last year. There's not enough money in the world to address the mental health crisis by treating symptoms. We invest far too little in understanding the brain itself and the underlying neurological roots of depression, bipolar disorder, and other common and challenging conditions. We've got to get ahead of that curve And if we do, the benefits to our health and frankly to our economy are impossible to overestimate. That's why Mr. Kelly, my friend on the tax committee, and I have been working on legislation to provide tax incentives for this sort of broad neurological research. Mr. Secretary, we're kind of fine-tuning our legislation right now, and I'd appreciate it if your team could take a look at and offer comments as we do this. Your support would be incredibly important and appreciated, and we can truly help people with mental illness challenges.
We look forward to working with you.
Thank you. I'd also like to ask about telehealth and telemedicine. As you know, Mr. Secretary, I've been working on this issue for a long time, since even before we were colleagues in this committee. And I wrote, along with Mr. Schweiker, the legislation that made telehealth available to seniors on Medicare during the pandemic that you referenced earlier in your testimony. That access provided invaluable, and it was the telehealth flexibilities that we put in place are set to expire at the end of this year. Mr. Secretary, how does your department view that upcoming deadline? Have you been evaluating the data coming in from the past few years? And can you tell us more about the need for this, the importance of this, and what you think we should be doing?
Congressman, I don't think there's any doubt that we need to maintain these telehealth flexibilities. In fact, even more so on the behavioral health side. When we hit the pandemic and we started doing telehealth, a lot of folks thought it wouldn't work on the mental health side, but it's actually one of the areas where we had the greatest success. And so the last thing we need to do is allow them to expire. We're prepared to work with you to make sure that you all are able to, on a bipartisan basis, reach some agreement on how to extend those flexibilities.
Thank you very much. And the chairman stated when he made his opening comments how important it is to provide health care opportunities and access to people in rural areas. And that's all underserved areas. And telemedicine is a way that we can really expand our reach. So thank you for your help, and I look forward to working with you, and I yield back the balance of my time.
Thank you. Mr. Smith.
Thank you, Mr. Chairman. Thank you, Secretary, for sharing your time here today. I'd like to start off with an issue that I've worked on for quite a while now, and that's TANF reform. I think there is ample opportunity to get some things done here. I, a while back, introduced Jobs for Success Act in the previous Congress, and to really focus on helping folks who need the most help, who are very needy, that in fact the neediest among us. One of the most important provisions of that bill, I will say, is that it would prohibit the use of TANF funds for families with income greater than twice the poverty line, so 200% of federal poverty. I'm pleased to see the priority was reflected as a key proposal in the Administration for Children and Families' recent proposed rulemaking on strengthening TANF as a safety net and work program. In fact, the very first proposal included in that proposed rule is to establish a ceiling on the term of needy so that it may not exceed a family income of 200% of the federal poverty guidelines. So I certainly appreciate that ACF recognizes this issue. So setting aside other issues of TANF, I'm wondering where we, I think there could be some other things that we would disagree on, but I'm just wondering if when it comes to establishing this ceiling of 200% of federal poverty, could you support the legislation? I've introduced the legislation already. Could you support that as a standalone measure?
Congressman, first, thanks for the work you're doing on this, because it is not easy. It will take congressional action to get reforms to TANF that will get it to work better, to do, as you said, to concentrate the money on the most needy families. We, as you mentioned in our proposed rule, look to try to do that as well, but we are absolutely prepared to work with you to see how we can do it, because if it's in a statute versus a regulation, far more powerful.
Okay, so I'll take that as a yes.
We'll work with you, because our own proposed rule is right now undergoing a lot of comment as well. So we're trying to take in comment to figure out where best to go. But without a doubt, you all will be indispensable making sure we can get TANF moving in a better direction.
Okay, thank you. Earlier this week, I'm glad our committee held a hearing in Texas to discuss problems that our constituents encounter in accessing emergency care. I'm glad to say that a critical access hospital, formerly critical access hospital in my district, Friend, Nebraska, previously having been critical access, shifted into the rural emergency health facility, and that was rocky. That transition was rocky. There's concerns that it didn't need to be that way, obviously, but wanting more information at the local level, they tried to get that information. It was not available. I think it took some 4 months for this institution, that was facing budgetary problems, to shift gears into this new category so that they could help their own patients. And so I'm just wondering, fortunately they had local government to help back them up, but not every facility would have that. So I know that this rural emergency healthcare designation is very new, but I'm wondering what HHS can do to make the process faster and even more transparent. And could there be a dashboard to allow the local level to pursue the status of where they stand at a given point in time so that they can get this done more quickly?
Yeah, and Congressman, you bring up a very important point in that this new classification will be very important for a number of these facilities. We want to make sure we do it right because, as you know, there's always an effort when there's money involved to game the system, and we have to make sure it's done right, so we reserve the category for those who truly qualify. I think with time, we're going to start to really get a better sense of how to move this faster for those who wish to qualify, but the best thing I can tell you is that we're going to do everything we can to sustain some of these hospitals and facilities in rural America, because if they go, there's nothing to replace them.
Okay, thank you. And just briefly here, I'm concerned that despite ongoing attention to the Office of Refugee Resettlements losing track of thousands of unaccompanied minors, I'm just wondering, do you truly believe that ORR is doing everything possible, especially when it appears that we've lost contact with nearly 20% of children released through the Unaccompanied Children Program?
Congressman, thank you for posing the question. And respectfully, I'm going to correct what you said. We haven't lost any child. Please remember that our jurisdiction that you all gave us, that Congress gave us, is for custody of children. Once we find a vetted sponsor, which we're obligated by law to do for these migrant kids, we lose all jurisdiction over them. We don't have the ability to follow up with them or require them to follow up with us. So it's hard to lose anybody you don't have jurisdiction over. Okay. What we do try to do is voluntarily keep tabs of them as we transfer them out to a sponsor. So but while they're in our care, they do not get lost.
Everything is working fine. Is that your suggestion?
In our jurisdiction, the custody that we have of kids, I welcome you to come and take a look. We are taking care of these kids. Now, what happens to a child once they're into the community and they get attracted to get a job at some meat packing plant? I wish I could tell you I could speak to that. Until you all give us jurisdiction to oversee some of that, I can't go there.
Well, last March, a year ago, I wrote a letter, got a response in July. I had to follow up in October and still haven't heard. So I'm concerned that there's problems. So I hope we can work together to establish a better system. Thank you. I yield back.
Thank you, Mr. Larson.
Thank you, Mr. Chairman, and Mr. Secretary, welcome back.
Mr. Chairman,
good to see you.
Good to see you.
Listen, President Biden's budget is an incredible vision for supporting seniors in this country, and his State of the Union message, I think as Americans were listening in, we're both bolstered by what he had to say about Social Security and expanding it, an issue I know that you care as deeply about as I do. But his budget also builds on the success that Democrats on this committee have had in lowering prescription drug prices. And this is a big deal, not only for seniors in my district, but across the nation.
Everywhere.
And the amazing step that was taken forward in terms of reducing drug costs has been incredible in terms of what it's meant to seniors. Now, as I indicated, and the President's budget calls on Congress to build on those successes. by capping generic drugs for chronic conditions. How, having viewed this from the position, both having sat here and now being in the critical position as secretary, how do you see that impacting and cutting costs for seniors?
Congressman, first, can I thank you for the dedication you've demonstrated on these issues for older Americans, and certainly your commitment to make sure we continue to improve Social Security. If you think about it this way, when you go to any American and say, what if I could tell you that you're not going to pay more than $2 out of pocket for a prescription medication, they'd say, get out of here. But now that we have said to them, what if I tell you you're only going to pay $35 for that insulin you used to pay $200 for, they say, hey, you know what? That's true, because now I'm getting it for $35. Now we're getting their attention. Now I think they're willing to say, well, maybe you really got something there. And I think the American public is beginning to see that we may finally get a grip on these drug prices and not let the pharmaceutical companies just dictate to Americans what we'll pay, because typically it means we're paying 2 or 3 times more than everyone around the world is.
What would you recommend that Congress do to build on our previous successes? And as you point out, to be able to say someone that $2 is the most you're going to be paying?
Well, the president put this prescription on your lap in his budget when he said, rather than only allow us to negotiate to bring down the prices of 10 of the most costly drugs for Medicare recipients, let us do 30, 40, 50 of those drugs. Why not save on all of them? And then he also said, hey, why don't we also make sure that if the drug companies are overcharging us beyond the rate of inflation, that we get to pull some of that money back for Medicare. And then finally what he said is, hey, $35 a month insulin, pretty good. For 65 million people on Medicare, that is very good. But how about the rest of the 330 million Americans? Extend the $35 cap for insulin to every American in this country. That's in his budget.
Well, that's extraordinary. Any idea, you went through the numbers there, et cetera, when we're talking about seniors specifically, you know, the 70 million Social Security recipients, what kind of costs are we talking about? And what kind of savings is that going to mean? You talk about kitchen table issues and discussions. Imagine the discussion at a table anywhere in America about what that would mean to individuals in terms of prescription costs.
I had a woman who was from Dallas who told me the story that in January, when the price of insulin had gone down out to $35, she didn't realize it. December, she had paid, I think she said she paid $117. She's on fixed income, relies on her Social Security check. She went into the pharmacist, purchased her insulin, walked out, looked at the receipt. She said, I felt so guilty, so I went back and I told the pharmacist, you undercharged me, I owe you some money. And he said, no, that's the new price, $35. She said, I was over the moon. I was over the moon because she did not expect to be saving so much money. For a person on fixed income relying on Social Security, that's a big deal.
Thank you, Mr. Secretary.
Thank you.
Yield back.
Thank you. Mr. Schweikert?
Thank you, Mr. Chairman. Mr. Secretary, a whole bunch of things, and so we'll try to do machine gun, but you're good at this. You've done this before. Since the data breach, one of the constituent work we're getting in our Phoenix office is a number of more entrepreneurial doctors who are having real trouble getting payments. So if you're doing some chasing of, you've been sending the money and it's not getting processed, particularly doctors' offices when I have casework saying they're having to open up credit lines. Thank you for chasing that down.
Congressman, if you want, we insisted that each of the payers, the insurance companies that make payments for the most part, that they give us a contact of who a provider can speak to who can actually make a decision on payment. So if you want to have your staff...
I'm going to have to reach out to you and get that.
Please reach out.
Because
please reach out.
I think we're writing letters to people. Two, and this is less because this is more a tiny diatribe. If I remember Inflation Reduction Act, we buy down the price of insulin. Wasn't the cost $16 billion? So we're functionally buying down the price to make it more affordable, right?
Actually, if you think about it, the fact that now insulin is being made available to people outside of Medicare for that price means we didn't pay a cent for that.
Well, actually, no. But we did spend $16 billion.
Yeah, I don't remember what the
Yeah,
cost
but my point is, you have Civica RX, 70 miles from here, making 3 types of generic, and their market price is actually cheaper than the subsidized price, yet we're handing cash to the very pharma companies that we were saying were gouging. And the reason I do that setup is conceptually, you and I have had side conversations now for years of there's an opportunity for a revolution around us if you want to crush the price of healthcare. A year ago, there was a company that came up with 3D printing for small molecule drugs. The fact of the matter that off-patent drugs in the United States are like 16% cheaper than the rest of the industrialized world. It's our ones that are on patent still. The fact that now you actually have some of the large pharma companies actually selling directly. You actually have some of the PBMs going into the manufacturing business. You actually have, my hunger here is maybe more of a side conversation because we're heading towards the time of the quality life year measurements that are used in Western Europe and those things, which is a rationing model, instead of a classic American model of let's make everyone compete with each other, let's open it up, encourage all sorts of different supply chains. You also touched, and this is just in that same vein, when I'm reading articles that are very hopeful of a fentanyl vaccine potentially coming and things like that, you're the 10,000-pound gorilla, in a nice way, in the marketplace. We're saying you want innovation, you want disruption, the technologies you and I have talked about. Yes. My frustration is we do talking about the financing of healthcare instead of what it actually costs. What technologies can you adopt either in the next breakthrough technology, the thing you blow into that knows you have a flu, and do you allow the algorithm to write a prescription? I know that's very controversial. To when the Joint Economic Committee wrote a chapter last March on what obesity, if HHS particularly went after obesity in America, morally, what it would mean to the economy, to the debt. It's a few $1 trillion over the 10 and would raise labor force participation, family formation, everything else. What can I do as one of the members up here to help that fixation on, let's make our brothers and sisters healthier?
Congressman, first I would say, keep the inquiry going because we're heading there. As we discussed just before we started this hearing, we're going to be heading there whether we want to or not, and we have to be ready to meet that moment, especially when it comes to the financing, because the structure we have is very obsolete. It's not geared for these new inventions. And the other thing I would mention to you is you should really, we really should get you together with our folks at ARPA-H.
I would like to. I wasn't going to, but ARPA-H can be incredibly impactful on taking on U.S. sovereign debt and making America healthier and more productive. But sometimes I have innovators that could not get a meeting or return phone call if their life depended on it. We're going to have to find some way to make it more robust.
Maybe we'll connect you with ARPA-H because they do have lots of folks inquiring because they have real money, and they're putting it out there to those small innovators who are just aching to have somebody make an investment in them.
Well, look, I believe the morality in the solution is in some ways the disruption, not just spending more cash on the model we already have. And with that, I yield back.
Thank you. Mr. Blumenauer?
Thank you, Mr. Chairman. Mr. Secretary, thank you again for joining us. I appreciate you starting your comments reminding us where we were 4 years ago. I mean, the sky was falling, people were running around lighting their hair on fire. We were deeply, deeply concerned about the economy, workforce. It's staggering what has happened over the course of the last 4 years. And I appreciate you providing that context because sometimes people forget how bad it was, the situation you inherited. I appreciate the partnership with the department. I'm excited in my state working to implement a waiver for Medicaid to demonstrate the power of food as medicine and innovation. And so far it's been kind of encouraging on the ground, and I hope we can continue. But you know where I'm going, I think, on my next question, because one area that I could not be more disappointed is what this administration has failed to do dealing with issues relating to cannabis. The president has made some minor adjustments. There have been a few people who have been pardoned. He commissioned an effort to reschedule cannabis. But Vice President Harris, just this week, was extraordinarily frustrated with the policies of her own administration. And she's right. I think it borders on political malpractice and beyond. This is an area that just breaks my heart. I am frustrated that the legislation we passed in 2022, which should have been fully implemented months ago, we're still waiting. Mr. Secretary, this is an area that is profoundly affecting millions of people in the United States. We are denying opportunities for research that almost everybody agrees could be transformative. And we're not in the forefront of this research. We outsource it to Israel or the Great Britain. There's no excuse for our not being in the forefront for something that is now legal for 97% of the American public. And where people have a chance to vote, they vote to change the policies. I am hopeful that we can see some action following through on the legislation I passed, but more importantly, on the things that the American people want. Treatments are being delayed, research is being denied, honest entrepreneurs are being caught up, and frankly, it's politically damaging to the administration. I would hope that you could work with us to be able to break the logjam, make the progress that the American people demand, and things that we could do in a matter of months. We've been dancing around this for as long as I've been in Congress. I've been talking to you throughout your tenure. I think it's time for the administration to actually follow through on some good intentions. Do you have any comment?
Congressman, I do, and I will take back much of your message. I do want to make sure I recognize that the work that HHS has done was pretty far-reaching and quite some time ago. We were asked by the President back in 2022 to take a close look at cannabis. We delivered. We finished our work last year, and we submitted, as we were required by law, our findings based on the science. We don't get to make the final call. That's left to DEA to make, but when it comes to cannabis, President asked us to do something, we did it. But I will take back the message to the administration where you stand.
We are missing an opportunity for the American people. And frankly, if I were the president and maybe interested in young people voting for me and being identified with change and reform, I think somebody ought to light a fire somewhere. There are lots of things here that people, deal with formalities. I've watched this administration jump into action 4 years ago when there was an imperative to do so. There's no excuse to continue dragging our feet on these formalities. The evidence is clear. The public wants it. There are millions of people who demand the products, and we are damaging a whole new sector of the economy. I think there ought to be a sense of urgency to fix this so the Vice President isn't confused. Thank you, and I appreciate your consideration.
Thank you.
Thank you, Mr. LaHood.
Thank you, Mr. Chairman. Welcome, Mr. Secretary. Glad you're here. Mr. Secretary, as the chairman of the Work and Welfare Subcommittee, we have responsibility, as you know, over TANF, the Temporary Assistance for Needy Families, which of course helps families move from government dependence to realizing their full potential through work. And we've been heavily focused in a bipartisan way on the subcommittee. Last year, HHS issued proposed rulemaking with substantial changes to the TANF program. In a letter to you sent in November by Chairman Smith and myself, we requested that HHS withdraw the proposed rule, which goes well beyond the statutory authority granted to the department, and we laid that out in the letter. Instead, our letter called on the administration to work with the committee to develop in a bipartisan way a proposal with legislative changes to strengthen accountability in the TANF program, which we think is essential. In your prior testimony before this committee, you indicated your intent, and we applaud you for that, for your willingness to work with Congress to make the needed changes to the TANF program. Further, in June of last year, in a response to the committee's letter expressing concerns about the welfare fraud scandal in Mississippi, former ACF Assistant Secretary Contreras indicated her willingness to work with us to improve TANF as well. And again, we commend her for that. Unfortunately, as we look at this year's budget, it did not include language regarding the reauthorization of TANF. And it appears the administration's intent is to sidestep Congress through this rulemaking process. And we share collectively with you the need that TANF needs to be focused on achieving its statutory purposes, and we've clearly demonstrated our intent to reform TANF through legislative action. The first of these reforms was included in the Fiscal Responsibility Act last year. Continuing our work on TANF, we have held 2 hearings, initiated a GAO investigation of non-assistance spending, and earlier this month, members of this committee introduced several bills to put in place guardrails to ensure TANF dollars are intentionally focused on removing barriers to work. I would also add, in fact, several of the reforms, Mr. Secretary, mirror the administration's own proposals and what you've talked about with TANF. And so, Mr. Secretary, I ask you again, will you work with the committee to develop a bipartisan proposal with our subcommittee with legislative changes to strengthen the accountability of TANF?
Congressman, we're absolutely ready to work with you. I think we've been in dialogue with not just your team, but many of the members on this committee's team when it comes to what we do on TANF. As you've mentioned, our goals are increase accountability. We want to make sure that there's a focus on family well-being and work. And we also want to make sure that states have the flexibility they need to make use of their dollars as best possible. But what we certainly want to make sure we do is avoid a court litigation on what we can and cannot do under TANF. That's where I think you all come in are very, very important, because to the degree that there are some questions about how far we can go with our regulations, you all have the statutory capability to make sure that we reform TANF in ways that bipartisanly get us moving, because I think all of us agree we don't want to see the kind of fraud or abuse of money for very needy families that we have seen.
And I guess, is there a reason why the budget didn't include the language regarding reauthorization of TANF?
Well, remember, we did have a proposal out on rulemaking. It's still out. We're still taking comments, and certainly this kind of discussion is good. My suspicion, and again, I can't tell you that I wrote every aspect of the budget, is that we think that there's a proposal that we put forward. We know that you all are working on legislation as well, and I hope what we can do is continue to work together.
Thank you for that. Also, our subcommittee recently held a hearing on modernizing child welfare, where we heard from witnesses with experience administrating Title IV-B child welfare program, which expired in 2021 and needs to be reauthorized. Witnesses shared with us how complex and duplicative child welfare funding streams are. The Biden administration has acknowledged the need to overhaul Title IV-B. However, the FY 2025 HHS budget proposes to increase funding without legislative changes. And I'm particularly interested in how we can make sure that Title IV-B is complementing the investment that we made in the Family First Prevention Services Act to prevent children from coming into foster care in the first place. Does HHS have a substantive legislative proposal for updating this program?
Congressman, I'm trying to think as to where we stand right now. We are trying to make sure that we implement with our proposed actions at the administrative level so that we focus on what the law requires us to make sure we're providing safe and proper care. As you know, we are trying to make sure that every child has access to a loving home, and so we're going to continue to push, at least at the regulatory level, to make sure that no child goes without access to a home that will be loving and safe and provide that child with the care that he or she needs.
And the last question, can we get a commitment with you on working on the reauthorization of Title IV-B?
Absolutely.
Thank you.
Mr. Pascrell, you are recognized.
Thank you. Thank you, Madam Chair. Welcome back, Mr. Secretary. Congratulations to you, your department, on the most successful ACA enrollment, as the ranking member referred to. Over 21 million people. Who would have thought 5 years ago? Selected in an ACA marketplace for 2024. 21 million people. And now states have expanded Medicaid. What do you know about that? And of course, the enactment of the historic Inflation Reduction Act, which capped insulin at $35 for seniors on Medicare. We've got to expand that, Mr. Chairman. So, you know my long interest in medical device safety. Now, I've looked back through the records over the last 20 years, and nothing has improved. Nothing. And I lost a friend because of a medical device, which piqued my interest 20 years ago. Currently, when a device fails or is recalled, it's very difficult to identify which patients will be affected. This leads to complications. It also leads to high costs. In 2017, HHS Inspector General found that recalls or premature failures of just 7 faulty cardiac devices resulted in $1.5 billion in Medicare payments to providers and $140 million in out-of-pocket costs to beneficiaries. I'm demanding unique device identifiers to be included in Medicare claims for ages. The process is interminable. I've been working on this issue for a decade. I'm a slow learner, but I'm getting there. What is the status of your department's implementation to include medical devices unique device identifier, the UDI, in Medicare cases, claims? I think all the parts of your agency need to be clear-eyed on pushing in the same direction to implement this comment. What's happening?
Garnison, thank you for the question and for your commitment to this issue over the years. I know that the entity that reviews this, the National Committee on Vital and Health Statistics, did not recommend that HHS adopt the new claims form that would deal with the unique device identifier.
Why didn't they?
I could get back to you on that. This is a committee that reviews those items, and I could try to get back to you to make sure that you have the answers to those questions.
Oh, wait a minute. I think I asked you an honest question. And we couldn't be talking about healthcare. We could talk about transportation. We could be talking about a lot of things. Oversight is important. And that sounds like an industry answer to me. Through the secretary. I don't like that. That's not how it's supposed to go. This has been going on not just yesterday. This has been going on for 20 years. People have died because of the devices did not work, were not able to handle what was supposed to be handled medically. And we can't accept it. And it seems to me everything that comes out, regardless who the president is, regardless of who the secretary is, it all sounds like the same thing. Everybody's protecting everybody, and people are dying. I have not got a good answer, Mr. Secretary. You're doing a hell of a job, but this area stinks. I have seen no difference between you and 20 years ago on this issue. And before I leave today, I'd like an answer, Mr. Chairman.
Congressman, I will give you the best answer that I, as Secretary, but more importantly, I, as a longtime friend of yours, can give you, and that is to say, this is handled by that particular committee. I don't sit on the committee. It is within HHS, and what I'm willing to do, because you're entitled to it, is to sit down with you and figure out what it is you need to find out about the work that was done by this committee that led them to say, not this time.
My personal and close friend, Joe Stefanik, had a hip operation. They found out the medical device that went in his leg and his hip had titanium. And it would seem to me that we just touched the surface because of Joe. And I followed his case very carefully, and we lost him. But the point of the matter is, that's just one case, very important case to me. Thank you, Mr. Secretary. Mr. Chairman, thank you.
Thank you, Mr. Pascrell. Dr. Wenstrup, you're recognized.
Thank you, Madam Chair. Mr. Secretary, good to see you today. Thank you for being here. I want to comment on a few things. You know, I hear a lot today about how more people have health insurance and all that, and I think that's a wonderful thing, but it doesn't always relate to health. It doesn't always relate to great outcomes. You know, as a physician, you know, often insurance companies, CMS, it doesn't matter who, they'll deny coverage, they'll deny or delay care. Sometimes they'll limit what you can do in an effort to prevent things. And we have some bipartisan efforts to try and reduce that and to make things better. And I was also appreciated your concern about the nursing homes, but what we failed to mention today is what happened in New York and some other states. You know, I treat a lot of infections. You quarantine people that are highly contagious. You don't take them and put them into a nursing home with the most vulnerable people that are going to die from that particular contagious infection. And that is exactly what happened. And it wasn't consistent with CMS guidelines. And we need HHS to be more outspoken on what happened here so we don't let this happen again. So those numbers are astronomical, but many of them were very avoidable. So I appreciate your concern there. I don't know where you stood on vaccine mandates, but you want to talk about confusing and aggravating the American people. It's you need to get this or you lose your job, which is not real good bedside manner, I might add. But it took away the doctor-patient relationship. We can't let that happen. Patients deserve the opportunity to talk to their doctor about what the vaccine is about, and what the potential side effects are, what the benefits may be. I'm vaccinated, and I got COVID, and I was out vaccinating people. You know, I understand the benefits, so I'm not anti-vax. I'm just saying, you know, that was a problem. But at the same time, what America saw, people coming across the border by the thousands, by the hundreds of thousands, not being tested and not being vaccinated. Yet other people in America, hardworking people, were put under that same pressure. It didn't make sense. We've got to be consistent with what we say and what we do, and we need HHS to lead on that in many ways. It created a lot of confusions. Listen, I want to thank you for spending time with the Doctors Caucus. I think we need to do more, either you or some of the senior leaders, because we have a lot of things we can do on a bipartisan basis to make things better. We need to be embracing the health of America, not just because you have an insurance plan. We need to embrace health, overall, education in health of our youth. Do they know what healthy foods are? You know, these are all the things that we can be doing and doing things that are preventive, actions that result in better health of America. I keep saying I want us to be the healthiest nation on the planet. And it's not just having an insurance plan that gets you there. There's so many things that we have to do. And you know, health and human services. Are our human services giving us a return on the investment? Are we creating healthier humans through the things that we are doing? That's the real question that we have to ask ourselves. We can talk about this plan, that plan. You know, I saw with TANF written down that they said that one of their missions is to prevent out-of-wedlock births. Prevent out-of-wedlock births. What are we, China? How come we aren't talking more in there about promoting healthy mothers and healthy children, which, by the way, we did through the McVie bill that we passed, bipartisan, and was signed into law by the president. Let's start recognizing the value of the healthy human life and go in that direction. So yeah, I'm taking this opportunity for messaging. That is what I'm doing. and I'm sharing with you the things that have people scratching their heads out there, right? But I will get to one other thing that you're probably expecting from me when it has to do with the No Surprises Act. And, you know, with federal court in 23 invalidated some of the HHS regulations, and I'll get right to the point. In January 12, 2024, the department decided to withdraw its appeal regarding several important parts of the court's ruling, which, one, prohibited insurers from using any out-of-specialty rates, and two, using the rates of other self-funded plans in calculating QPAs. You know what I'm talking about. And it's been more than 2 months since that decision, yet we haven't really seen any guidance instructing on that. Maybe it's been out there, I haven't seen it. We need to be instructing insurers and IDRs to follow the law. And I just want to know, when will the department be issuing that update?
Congressman, we are, as you know, we're undertaking some audits on how those QPAs are being applied, what's underlying them, and I'm hoping that pretty soon, whether it's at the Doctor's Caucus or in another hearing, we'll have some information to provide you. In fact, because there's so many of these audits that we're doing, we'll probably start to post them as quickly as they start to come out online so people could start to see them. But we're hoping that this informs everyone on what is expected when we talk about these QPAs, because we want to make sure that we don't have the issuers, the insurers, using a wrong foundation for which to, you know, market, or excuse me, to price the service. And so these audits will be very important, and we'll stay in touch with you on that.
Please do. That'd be very helpful every step of the way. Thank you. You're back.
Mr. Davis.
Thank you, Mr. Chairman, for this very informative hearing. Mr. Secretary, let me thank you for your many visits to Chicago to meet with the provider community, meet with consumer groups. We feel like you are almost a part, or we'll just make you an honorary part of our city, and thank you very much. As you know, I've worked closely with our friend John Lewis on a Ways and Means Committee investigation of discrimination against potential foster and adoptive parents based on religion and LGBTQ status during the Trump administration. The results were alarming, particularly given that LGBTQ youth are overrepresented among older foster youth and more likely to suffer additional trauma while in our care. John hated discrimination in every form and championed legislation to address it. I'm honored and pleased to carry on his work, and I know that he would be proud that you and President Biden are carrying on his work with your budget proposal. I hope to work with you to ensure that our most valuable, vulnerable foster youth are affirmed and loved. I also want to raise a serious problem that children with sickle cell disease are having access in supplemental security income benefits. I've had the opportunity to speak with SSA Commissioner O'Malley, who has begun an expedited process to address the problem. The commissioners told us that they are consulting with sickle cell experts at HHS to make sure they get it right, and I appreciate anything you can do to facilitate this. A lot of families are counting on us. I also want to associate myself with the discussion generated by Representative Larson. I too have a large senior population, and everything that we can do as it relates to their well-being, I appreciate. But I wanted to ask you a question relative to the whole business of violence prevention and how the department is handling it as a part of health and medicine and a part of the public health spectrum that we find ourselves in.
Congressman, as you know, we at HHS have declared gun violence as a public health crisis. We have also, in this budget, made commitments of resources to be able to do further research to find out what drives the violence, what can we do to try to most effectively prevent it, and we continue to make investments, especially in the mental health field, to try to address not just the consequences of violence that occurs and the trauma that many face, including young people, but also what we can do to try to prevent that type of violence from ever occurring. We look forward to your support in that effort because we are so far behind in the work that can be done, but there is no doubt that the more that we invest in this area, we're going to find out that we can reach families before they have a crisis and suffer the consequences of violence, especially gun violence.
It was my pleasure to see you with the federally qualified health centers. And of course, we go way, way back with them, as you do. For the future, in terms of the roles they play, would you just comment?
Without the federally qualified health centers, probably hundreds of thousands of Americans, more Americans would have died from COVID. Without the federally qualified health centers, so many children would have access to dental services, preventative health services that they need. Without the federally qualified health centers, many of our schools could not afford to have a nurse or other caregiver available at the schools. And so President Biden has doubled down on the federally qualified health centers because not only did they deliver during COVID, but they've delivered for principally families that are low income and don't have other access to care than those community health centers. And we're going to continue to make investments in them. We look forward to working with you to make sure that that happens.
Thank you very much, Mr. Chairman. I yield back.
Mr. Arrington.
Thank you, Mr. Chairman. Mr. Secretary, thank you for your service to our country. I'm going to run through some things that I want to note for you and your consideration and observations that I want the American people to make. I don't think there's a clearer or starker contrast between the President of the United States, Mr. Joe Biden, you and the Democrat Party in terms of your view of the role of government, your policies and plans for the future of this country, and the policies and plans of Republicans. I'm generally speaking here, but there's a significant philosophical divide, and so I recognize that. I don't expect you to come up here promoting policies that I think would be better for the country, but as budget chairman, one of the things we all have to do is find a way to rein in deficit spending that's now at $2 trillion, and a debt that it's 34, and an interest on the debt that is going to be $1 trillion, which is more than what we spend on all of national defense. President Biden's budget, I'm sure you're aware of this, is the highest level of sustained spending in the history of the United States. Of any budget ever submitted in this building, in this institution, highest ever. And because of its high sustained spending and borrowing, even with $5 trillion in taxes, Mr. Secretary, we leave our children and our grandchildren, generations of Americans, with $16 to $17 trillion more in debt, even after trillions of tax hikes on families, small businesses, et cetera, et cetera. Our plan's different. We balance in 10. That's the plan. It's got to be followed, but that's the blueprint. We rein in spending. We root out waste. The $2.3 trillion in improper payments, $50 billion in Medicaid last year, but that's not picking on Medicaid. It's in every entitlement program. We reignite growth. We get 1%, which is $3 trillion. We don't raise taxes. We bring down the debt to GDP by 40 points. Now, we can debate the details of it, but those are the different views of the future and our children's future in this great country. When I look at the healthcare side, let me make some observations. For example, you all suggest that you're going to somehow shore up Medicare and the Medicare Trust Fund. Hey, great. We should work together to do it, quite frankly, because that's the only way it's actually going to get done. But I want to make sure that we have a little bit of, sort of an honesty and test here on this. When you propose in the budget saving $200 billion with your price controls. You double down on it, saves $200 billion as opposed to $100 billion in the IRA. And then you raise taxes, payroll taxes, about $750 billion. Combined is the money you use to put to, presumably, to to the Hospital Insurance Trust Fund or Medicare Trust Fund. But my question to you is, why should we believe you're going to do that? Because when the Democrats had total control and this administration was in charge, the $100 billion that was saved from the IRA out of Medicare was used to subsidize green energy tax subsidies. So now you're telling me you're going to use $200 billion when you double down on that out of the savings of Medicare to save Medicare. It doesn't add up, okay? So that's one. Secondly, Medicaid. There are studies that say that people without insurance do better in terms of outcomes than people on Medicaid. So we got to work to make that program work for our most vulnerable. Here's the deal, and this is a question I'd have for you, but I don't have time to ask it. Maybe you will respond somewhere in this session. But did y'all fix the inequity? Because I hear a lot about inequities from this administration. How about the inequity in terms of the match that you all give to the single adult population, the Obamacare expansion of Medicaid, versus the sickest, poorest, most vulnerable among us? There's a much higher match on the single adults. There's a great place that we can equalize the payments, save some money, and help the most vulnerable. Site neutral payments. We should be paying hospitals the same amount that we pay independent physicians for the same outpatient procedures. If we did that, we save $120 billion. Now, where did that idea come from? Over 10 years. That idea came from President Obama. We used President Obama's good idea, put it in our budget. Why isn't that in y'all's budget? Maybe there's a good reason, but you already have a bipartisan significant saver there. The last piece I'll mention that drives me crazy is the Obamacare subsidies to people making, half of whom will make over 400% of the poverty level, some of whom make $500,000 or more. The only answer to that is that you're trying to drive everybody into a public health system, into a single-paid system, into a government-run system. I mean, I know that's the philosophy. Respect it. We can be honest. We can debate it as which one works best. But that's what you're doing. Why would the taxpayers subsidize people making $500,000, $600,000 to go into a government-run health care, many of whom already have private insurance? These are my concerns. I put them before you for your serious and sober considerations. I appreciate your service to our country.
Thank you. Ms. Sanchez.
Thank you, Mr. Chairman, and thank you, Secretary Becerra, for being with us as we work to continue building on the numerous accomplishments of the Inflation Reduction Act. The IRA is why more Americans have health coverage today than ever before. The IRA is the reason why 4 out of 5 people have access to high-quality care for less than $10 a month. The IRA is why seniors only pay $35 per month for insulin and will pay no more than $2,000 a year of out-of-pocket costs for their prescription drugs. And in September of last year, the administration built on those protections for older Americans when it proposed minimum staffing standards in nursing homes. And these were indeed long overdue and necessary protections. During the pandemic, understaffed facilities were twice as likely to have COVID-19 outbreaks as comparable facilities with higher staffing levels. And unfortunately, a recent OIG report still found inadequacies in infection control practices. Yet just 2 weeks ago, this committee marked up legislation effectively rescinding this nursing home staffing rule that the Biden administration recently proposed. Many of my colleagues and nursing home operators have claimed that this rule would devastate the industry, forcing closures across the country and impeding access to care. Mr. Secretary, does the Biden administration's nursing home staffing rule include an exemption process for nursing homes in this rule? And can you walk us through that process for facilities that are not able to staff accordingly?
Congresswoman, thank you for the question, and great to see you again. Yes, we do. We have exemptions. There are hardship exemptions. We look at rural facilities differently as well. We try to make sure that those that always have a harder time competing and staying afloat because of where they are, for example, in rural settings or among a disadvantaged community, that we try to make sure that we take into account some of those hardships so that they don't have to move as quickly as others that are more prepared and equipped.
So unlike what was said numerous times, it's not a one-size-fits-all.
That's correct.
rule. Thank you. Private equity investors have also continued to flood the nursing home sector as a particularly lucrative investment. For-profit and private equity-owned nursing homes are less likely to have quality care or adequate staffing, and they often use complex ownership arrangements to hide their massive profits. How is HHS addressing transparency in nursing home facilities and their ownership agreements to ensure that our Medicare dollars are actually being invested in patient care and not lining the pockets of those who already have?
Congresswoman, as you're aware, we are now requiring the disclosure of ownership, and while there are many layers oftentimes behind who is the actual owner, we're trying to make sure that we open the curtain so that everyone gets to see who truly owns that nursing home facility.
Great. I think transparency in anything is always a good rule of thumb. Lastly, Secretary Becerra, I want to mention an issue that is personal to me because both of my parents suffered with Alzheimer's disease. I have a bill called the Change Act, which I've introduced for the last 5 years. And what this bill would do is improve early detection of Alzheimer's and other dementia and cognitive decline by authorizing clinicians to use a qualified tool to detect cognitive impairment during the annual medical wellness exam, which is a preventive measure. So if once a year folks are going in for a complete physical, they're also being tested for a baseline of their cognitive ability, and over year, they're testing to see if that cognitive ability is declining. And it's important for many reasons, not the least of which is many times, particularly in communities of color, Alzheimer's goes underdetected, and it's often not diagnosed until medium to late stage, when some interventions are no longer necessary. Both my staff and Mr. LaHood's staff have consistently engaged with CMS to implement this administratively, most recently meeting with CMS on the technical updates that we made to the bill on CMS's suggestion. I just want to urge you to work with me in making this small but very meaningful change that I think would help many of our nation's seniors and the family that give them care when they are diagnosed with dementias. It's relatively low cost to implement, and with the innovation in potential treatments for for Alzheimer and dementia early on, I think it could be a real valuable tool.
Congressman, we can follow up with you. I can commit to you that my team and I will be ready to work with you and Mr. LaHood.
I appreciate that very much, and I yield back.
Dr. Ferguson.
Thank you, Mr. Chairman. Mr. Secretary, thank you so much for being with us today. I know you and I have spoken in the past about the challenge that the healthcare system and Americans are facing on antimicrobial resistance. This is something that cost our system tens of thousands of lives and over $4.5 billion a year. We've talked about some of the challenges with the innovation, research and development, and we've got a bill out there called the Pasteur Act that creates a unique pull system to pull these drugs into the market. Do you believe that congressional action is needed to address this issue?
Absolutely agree with that, and thank you for the effort. It's not been an easy road, but we absolutely need something because we're not going to get the medicines and the attention that we need unless we have congressional action.
And look, we appreciate the commitment through things like BARDA, and there's been a longstanding commitment to doing the basic research, but when these small innovative companies, they almost go bankrupt getting the product developed, we have to develop that pool. So I appreciate your answer on that. I want to go back. When the question was asked about the hospital in Denver, the Safety Net Hospital, and you said you would work with them. We've got about 10 million people conservatively that have come across the border in the last 3 years. With 10 million people, you're going to have a lot of those folks that are going to get sick, they're going to break a bone, they're going to have a baby, stuff is going to happen. Where does the money come from? What pot of money comes out to help? a hospital in Denver with that? Where does that fund, you said you'll work with them. It's going to take money. Where does that money come from?
Congressman, thank you for the question. Now, let me speak to you from the perspective.
Well, no. If I could interrupt.
Okay.
Who is paying for that right now?
Okay, so you're asking me to put myself in the shoes of that facility, and it's without being actually the person in the shoes. It's hard for me to give you a precise answer.
Somebody's paying for it. I think if you could get back to us with a summary of who is paying for the care of the folks that are in the country illegally, I think that would be helpful. That's probably a longer answer, and if you could submit that to us in writing at a later date, we'd greatly appreciate that. I just want to understand where it's coming from, because if it's coming from the local level, that puts a tremendous burden on that local hospital. If it's coming from the federal level, that's an expense and a burden on our budget that, you know, we have to figure that component out. So if you'll come back to us on that. You know, you've heard about, again, the one-size-fits-all policies with the nursing homes. Again, I just want to emphasize, I'm not going to beat on this point, but it's not working, and that will not work in rural America. It does not matter how much you pay folks. We simply don't have enough healthcare workers there to meet what the proposed rule is. And I know that y'all have been investing in healthcare workforce, but that's not happening fast enough to keep up with the proposed changes. And
Congressman, if I could.
Yes.
Because it is not a one-size-fits-all proposal. And for rural communities, the standards are different than they are for large, denser populated urban areas. So just to be sure, it's clear that how it would work and apply to a facility in a rural setting is different from how it would work in an urban setting.
And again, I'm going to fold in another component of this. When you're in a rural area, and I'm in a rural district just south of Metro Atlanta, we've got a problem with the wages down there potentially coming if we look at if we don't extend the low wage index hospital policy. It's too easy for nurses, physicians, other providers to drive 40 minutes to Metro Atlanta to get 3 times the wages. So that's something that's got to fix. And I would just ask that you would commit or find a way to do an extension of the low wage index hospital policy.
We're committed to work with you and others who have an interest in making sure we have a good policy.
Thank you. One final thing. 14 years ago with the implementation of the ACA, it was supposed to be a panacea of things that worked well. I'll ask 3 questions. Number 1, is health care less expensive today than it was 14 years ago? Are Americans as a whole healthier today than they were 14 years ago? And while you may have access, is utilization amongst our most vulnerable better today than it was 14 years ago? By every metrics that I can find, healthcare costs more. America as a nation is not healthier, and we still have an immense problem with utilization by the folks that are the most vulnerable. So with that, I make that comment that we can't view it as the system is perfect right now. We've got, before we go dump a couple of $100 billion more into raising the subsidies for wealthy Americans, we've got to fix what's broken in the system. With that, Mr. Chairman, I yield back.
Thank you. Mr. Estes?
Thank you, Mr. Chairman. Secretary Becerra, I'm glad you're here for this important hearing, as your agency's budget request is somewhat troubling in what it includes and what's absent from being included. I mean, as several of my colleagues have noted, there's hardly a mention of the greatest health crisis that our country's facing, the fentanyl epidemic that spiraled out of control thanks to the open border policies that President Biden has been promoting. However, my concerns aren't with the budget, but also with the policies HHS is elected to pursue, even over opposition from this committee and community health leaders across the country. Mr. Secretary, I'm immensely concerned about the nursing home staffing mandate that the agency proposed last year. I know several other members have talked about that. I mean, the rule that's currently under final review at OMB suggests that you're pushing ahead to finalize it, despite the fact that thousands of nonprofit nursing homes and organizations, particularly representing rural providers, oppose the mandate as it's written, including nearly 1,000 that signed a letter to this committee in support of the bill to prevent the rule from being finalized. And I know there was comments earlier about the number of people that died during COVID in a nursing home. That's really not apples and oranges in terms of comparing that. I mean, the problem with people dying in a nursing home was because governors in states like New York and New Jersey and Michigan ordered sick individuals to be put into the nursing homes, thereby to infect so many other residents. So I don't know that we want to use that as a standard for moving forward during a non-pandemic time. Mr. Secretary, can you remember the amount of money that your agency estimated compliance would cost nursing homes in Kansas?
Congressman, can you repeat the question?
Do you remember the amount of money that you've assigned or that you'd estimated would be compliance costs for the mandate in Kansas?
I'd have to get back to you for Kansas in particular.
That was a little bit of a understand. I didn't expect you to really to know. I know with all the states you have to deal with. But I'll jog your memory. It was $25 million for the state of Kansas. But along with the mandate for across the country, it also provided $75 million to improvise and support the nursing workforce nationwide. I wanted to point out that $75 million is the same amount that my home state of Kansas will have to expend over 3 years. So it's less than 1 year even of implementation in your home state of California, where the agency estimates that it costs $222 million annually. We've heard nothing from the agency about how you're going to spend that $75 million. Can you tell me, can you talk in details of how you're going to spend that money? What do you expect it to cover? How do you expect it to move the needle to enhance our staffing shortages?
Absolutely, Congressman. And if you recognize that we don't run nursing homes, we don't run most healthcare facilities, we support them. And the way we do that is through the states. And so when the president wanted to put out the $75 million to help boost the workforce, to help make conditions better, it was in partnership with the states. So the states and the local health entities that would apply to get the money are the ones that would determine how it would be spent. What we did was we put guardrails to make sure how it could be spent, but then we leave it to the state and locals to determine who gets it.
Right, but I mean, $75 million won't cover $222 million in your home state of Kansas for 1 year, or your home state of California. I guess I really have concern about the mandate wasn't really thought out, and that the support for nursing home workforce really wasn't necessarily good leadership or good, that there was pre-thought in terms of how to make that happen. I do have a bill, like most of us up here, in terms of talking about how do we move forward. We've got a bipartisan bill called Ensuring Seniors Access to Quality Care Act, which would allow nursing homes that have been forced to suspend their in-house CNA education programs due to restrictions from violations to resume those programs once the quality standards are met. It's a common sense bill that actually accounts for some of the current workforce challenges that nursing homes face, and without compromising the commitment to quality care for residents. And it's not something where we're throwing money at problems. We want HHS to help commit to advancing creative solutions that'll help address some of these problems healthcare providers and patients across the country face. And we know, as mentioned earlier, in rural areas it's harder to staff. These challenges are even more acute and add to the burden and worry of patients in rural areas. A recent survey showed that 58% of rural hospitals are at risk of closing, with 82% losing money on patient care. And currently in Kansas, my home state of Kansas, there's 29 hospitals in Kansas at immediate risk of closure, which accounts for about 28% of the rural hospitals in the state. So obviously there's some healthcare concerns we've got to address. Unfortunately, I'm out of time, and I don't have time to ask you any more questions about these issues. Mr. Chairman, I'll yield back.
Thank you. Ms. Del Dene?
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for being with us today. As you know, every day 17 Americans die waiting for an organ transplant. A transplant provides a new lease on life, but our current system is woefully inadequate to meet the needs of the more than 100,000 people on the wait list. A big part of the problem is that 1 out of every 4 recovered kidneys go unused due to mismanagement, outdated technology, and other inefficiencies. And so we have to do better. Last year, Congress passed legislation that gives HHS the authority to update our broken system, but this opportunity will be lost if Congress fails to fund these reforms. And so I appreciate the President's budget request of $67 million to reform our nation's organ transplant system. I wondered if you could highlight for our committee why this funding is so critical and some of the reforms the funding would go towards.
Congressman, thank you, and very much appreciate your role in trying to move this, because there are Americans who are dying because they can't get their transplant. We need to get rid of the monopoly. We had a monopoly that was running the organ transplant system, and it wasn't working well. And the reforms, and thank you very much for the work on the reforms that are now in place, are going to let us remove that monopoly, put in place a board that will oversee the operations of the organ transplant system that is not biased, not based on profit, but is there to do the best for patients. And then we're going to go out and competitively bid a lot of the operational work that has to happen so we can make sure we connect the dots right away. But we can't do that without the resources. And that's where Congress is indispensable. If we're going to implement your reforms, we need Congress to come up with the resources.
Thank you. Also, the rate of living donations has largely flatlined over the past 2 decades. This is in part because living donors face thousands of dollars in out-of-pocket costs when they're donating, including things like travel expenses, lost wages from taking time off of work, and childcare. And no one should have to pay to donate a life-saving organ. The Living Organ Donation Reimbursement Program helps low-income donors defray these costs by reimbursing up to $6,000, but current restrictions severely limit this program's impact. So, for example, 1 in 5 donors hit the $6,000 cap, and income rules disqualify individuals making more than $53,000 a year. So my office has been working with your agency on draft legislation intended to provide greater support for living donors. Do you agree that we should prioritize this effort so that we can save more lives?
Actually, absolutely. It's not just good for the folks in need of a transplant. It's good for the economy and our taxpayers because it will cost us less at the end of the day.
Thank you. And then for the past 5 years, I've helped deliver funding for the Kidney X program, which has invested $50 million so far in public and private dollars to develop the world's first artificial kidney and other breakthrough innovations. I'm very concerned that the President's budget appears to eliminate this critical program. I wanted really to know if you can ensure that HHS will continue the mission of Kidney X. The expense for kidney care is great. The opportunity is incredible. And continuing Kidney X means funding cutting-edge research to prevent and treat kidney diseases, including through the ARPA-H initiative. Can you support that?
Congressman, again, your efforts here are notable, and what I would say to you is that the initiative, which began as an effort to really jumpstart what we do with regard to those in need of kidney support, is one that, while it has value, it costs money. And at this stage, what I can tell you is that we will work with you and others in Congress to see where we can land. But given that the Department of Health and Human Services is taking the largest cuts of any department in the federal government when it comes to this latest budget, we're having to make decisions. But we look forward to working with you to see where we can go.
And, you know, Kidney X has been funded at incredibly small amounts. We're talking just a few million, single-digit $1 million that can have an incredible impact. In fact, we should be doing more because private dollars come in to help, and the amount that we spend to treat kidney disease across this country, new innovations could be hugely life-saving and make incredible difference in the amount of money that CMS spends here. So I hope you'll continue to look at that, and thank you so much for being here. I yield back, Mr. Chairman.
Mr. Smucker.
Thank you, Mr. Chairman. Good afternoon, Mr. Secretary. I'd like to just weigh in as well on the nursing home staffing mandate based on experience we had in Pennsylvania, where we see less access to care. Pennsylvania just recently went through the phase 1 of implementation of a statewide staffing mandate. And we found 80% of nursing homes in Pennsylvania have resorted to using temporary workers for NPA, LPN, and RN shifts. And 58% of those nursing homes have had shifts go unfilled even when they were using temporary, because the temporary staffing agencies couldn't find people as well. And so we've literally had homes reducing beds, reducing their census because they didn't have the help to meet those standards. They estimate if these new federal standards are implemented, 62% of Pennsylvania's nursing homes are expected to further reduce their census. There'll be an estimated cost of $463 million for our facilities in Pennsylvania to comply. Are you concerned about that? I'm just not sure. I understand the need to ensure that seniors are well cared for, but I'm really concerned that this is the wrong formula to do that. Are you concerned about nursing homes not having the staff and so being able, reducing the number of beds they have available?
Congressman, thank you for the question, and look forward to any information you'd like to provide us. We've heard a number of things from a number of different sources about where the nursing home industry is. I will tell you, it is somewhat confusing to hear on one end that private equity firms in Wall Street are looking at nursing homes to make investments because they see that there's money to be made, and on the other end, people saying there's no money and therefore we cannot staff up to levels that will provide quality care. So I will tell you that I'll take a look at any information you have. I will look at it very closely, because what we do know is that right now too many Americans send their loved ones to nursing homes and they don't get the kind of care that they would expect, and no one should be forced to send their loved one to a place that doesn't provide quality care. We all should live by certain standards. And we think that having minimum standards, if you're going to call yourself a nursing home, you should have a nurse. That's pretty basic.
I could see minimum care standards, which I think we already have. And it's not money, they simply do not have bodies, do not have the nurses to fill the spots. And I'll be glad to share some of the information that I've received in regards to the situation in Pennsylvania. I do want to bring up another situation. The Coverage with Evidence Development Program, or CED, of course, is, we all, again, agree that beneficiaries deserve access, Medicare beneficiaries deserve access to new medical devices, drugs, and technologies. And of course, with this program, with the delay in getting drugs out of the program, it has been a hindrance to individuals, to seniors' access to treatments, I believe. There are currently 22 products under CED, 6 of which have been with the program for 15 years, which I think is unacceptable. And a 2023 MedCAC report even recommended recently that there be a clear process for timely completion of the CED studies. I'm working on legislation in response to the recommendation that would establish a straightforward process for ending CED. And my staff has received technical assistance from CMS on that proposal. So wondering whether you'd work with me on that. Do you agree that the current timeline is unacceptable, and would you be willing to work with me on the issue?
Congressman, I know that my team has had an opportunity to work with your staff, and we look forward to working with you on this particular issue.
Thank you. Look forward to that as well. I want to mention is one additional thing, again, relative to the situation in my district. Last February, the Biden administration issued a proposed rule that would eliminate moral exceptions to the Affordable Care Act that protect individual small business, nonprofits, and other entities who object to providing health insurance coverage for contraceptives. And whether you believe that they should provide that or not, in my district, Conestoga Wood brought a case to the Supreme Court where it was decided that businesses like theirs who objected due to their religious beliefs to providing access to comprehensive, that should be protected. This is what the Supreme Court decided. So I think you're going against the decision of the highest court in the land in mandating coverage of contraceptives. It directly violates that ruling, and I'd like to hear your explanation for that.
And thank you for the question, because it does get a little technical. The law requires, the Affordable Care Act provides that every person is entitled to receive preventative health care services. Contraception care is considered preventative health care services. Where there are religious or conscious objections, those objections should be respected, but that doesn't absolve the provider or the payer from providing that individual who needs the care with
But I think
access to
you've
the care.
just now calling it a moral objection, you've somehow trying to sidestep that ruling. So
No.
I'd like to talk with you further about that because I think
But we do respect the conscientious objection, but that that should not prevent the individual, the patient who's supposed to get care, from receiving the care through some fashion that doesn't violate the religious objections that someone would have.
Well, I'm well out of time. We're glad to talk about that later. Thank you.
Thank you, Mr. Hearn.
Thank you, Mr. Chairman. Mr. Secretary, it's always good to see you. Thanks for being here. The Federal Tax Refund Offset Program is a vital piece of the Child Support Enforcement Program. This offset program is when a non-custodial parent is due a refund but owes past child support. Treasury can withhold the tax refund and send it to the state child support agency to get it to the family so these children are properly supported. 60 tribes across the country provide and manage their own child support services, 10 alone in my home state of Oklahoma. Sadly, under current law, none of these tribes have direct access to the offset program. This means tribes are either forced to contract with states to get access to the program or forgo this vital program altogether for their families. This is devastating for thousands of tribal families across the U.S., and we must work together to grant tribal child support programs with direct access to the offset program. Mr. Secretary, the President's 2025 budget includes a proposed fix to this issue and provides tribes with access to the federal tax refund offset program. Do you have an estimation of how many tribes are currently forced to contract with states to get access to the offset program, and how many don't currently have access at all for their families?
Congressman, I don't have that with me, and I have a pile of papers, but I don't have that with me. But we could get back to you because you've touched on a very important issue.
Yeah, I thank you, and I appreciate it. You know, and there's a lot of people depend on this, and having seen this early in my childhood, I think it's important that we have responsible parents, and being able to have that offset is really important. And so I look forward to working with you on that. And Mr. Secretary, healthcare treatments are rapidly changing and advancing at times, and federal healthcare programs fail to keep pace. I don't have to say this as a criticism, it's just a fact. An area that is proving worthy of further exploration and expansion is prescription digital therapeutics, which offer unique and promising ways to help cancer patients and those with behavioral health issues, key priorities of this administration and this Congress. Will you work with us to create a reimbursement mechanism so that we can ensure that Medicare beneficiaries have access to these treatments?
Congressman, we look forward to working with you.
Well, I appreciate that because I think we all know that it's very important as we go forward in offering these services and being able to get it to our Medicare patients. Finally, one that's probably a little more touchy, that is on the hearts and minds of many people across America, not just in Congress, but certainly in the political world today, but it's because it's so important to the American people, and that's what's happening at our southern border. Public schools have been shut down to house illegal immigrants, hospitals have been financially ravaged, and the influx of fentanyl has killed hundreds of thousands of Americans and is not slowing down. This administration continues to either willfully ignore or hide from the public the true extent of how the crisis at the southern border is harming our country. Within the past year, I've been to Asia, Europe, and South America, and I've talked to every leader in those particular areas, including presidents and people from our own State Department. And there's not a fentanyl problem east and west of Mexico or south of Mexico. The fentanyl problem flows north out of Mexico into the United States across our southern border. And this problem is getting worse. The DEA has reported that sharp increase in fentanyl mixed with xylene is being trafficked into our country. This mixture is even deadlier than fentanyl alone, and even Narcan doesn't work to reverse the mixture's effects. It is now blatantly obvious that this drug is being weaponized against the American people. There's no other thought when you look at the cost per pill of roughly $1 to $2. Secretary Becerra, your department sees the damage that fentanyl has done to so many individuals, yet the world fentanyl is mentioned in President Biden's 2025 HHS budget a whopping one time. Even though this is clearly a public health emergency. Can you tell us how you expect to curb these fentanyl deaths and help with struggling addiction when the southern border continues to stay wide open and allow the free flow of fentanyl to our country? And I'll give you the balance of the time.
Congressman, thank you very much. I can tell you what we are doing, what the President has asked us to do, and the resources he's giving us at HHS on the healthcare side to deal with fentanyl. We are moving forward to try to make naloxone and other treatments that can counteract the effects of fentanyl overdose to keep a person alive more available. And today there are thousands more Americans who have access to the drugs they need to counteract a fentanyl overdose. We are continuing to make the types of services that work to keep people from dying available. So something as basic as a fentanyl strip, which lets someone know if they're addicted and they're about to shoot up, find out if that drug that they're about to ingest and put in their body is laced with fentanyl. That can save lots of lives.
Mr. Secretary, I have to take the last 9 seconds. I apologize.
Okay.
But wouldn't it be better if we just stopped the flow across the southern border instead of trying to find all these Band-Aids to fix the problem? That's all I'm saying.
Clearly
and it's flowing from Mexico clearly to the United States. I yield back, Mr.
And the
Chairman.
President has been doing quite a bit on that. Again, I spoke to you from the perspective of HHS.
Thank you. Appreciate it.
Thank you. Ms. Chu?
Secretary Becerra, it's so wonderful to see you since your first elected office was representing me in the California legislature nearly 40 years ago. So to see you in this position is just wonderful.
Thank you.
I wanted to talk about the administration's commitment to reproductive health, including the Title IX Family Planning Program. And I'd like to bring up the issue of contraceptive access, which is more urgent than ever considering the ongoing attacks on reproductive rights around this country. As you just said, the ACA requires health insurance plans to cover preventative services, including birth control, at no cost to the patient. But for years, there have been extensive reports of plans failing to comply by illegally denying coverage, delaying claims, requiring cost sharing, forcing step therapy, or failing to maintain a transparent exceptions process. Now, I appreciate that HHS recently released new guidance for insurers recommending they cover all forms of contraception, including a therapeutic equivalent, otherwise known as generics. But many of us members are very concerned about compliance with this, and that's why 143 House members and 13 senators signed a letter to the health insurance plans asking whether they're going to comply with this therapeutic equivalent standard. So my question is, how will the department enforce this new guidance to ensure that everyone has access to the birth control that works best for them?
Congresswoman, thank you for the question and actually for your just intense dedication to trying to address this. We have met with the plans and the plans representatives. We have met with pharmacies and the pharmacy representatives to make it clear that under the law, they must make contraception medications and services available at no out-of-pocket cost. We've also told them that we have enforcement authority under Section 1557 of the Affordable Care Act, and we are prepared to use that. We also we've explained to some of these entities that because they rely on services and reimbursement for services based on Medicare and Medicaid, that they must abide by federal laws in order to continue to receive those dollars. So we're going to use every lever we can to make it clear that there are laws in place that protect patients' access to care, and we will do everything we can to enforce those requirements and protections.
Thank you. That is so reassuring to hear. And then on a different topic, I'd like to bring up the role of artificial intelligence in Medicare Advantage coverage determinations. I'm concerned that the increasing use of AI in coverage decisions has resulted in wrongful denials of medical care for an alarming number of seniors enrolled in Medicare Advantage plans. In fact, there's a class action lawsuit going on right now against one major insurer's use of AI to deny medical claims where AI systems allegedly played a role in the denial of over 300,000 payment requests within a 2-month period. The average time spent supposedly reviewing each of these claims was a mere 1.2 seconds. So in response to these care denials, I sent a letter to CMS last November with 30 other House Democrats expressing the need to increase oversight of the use of AI in Medicare Advantage payment denials. I appreciate that the administration recently issued guidance that aims to increase oversight of AI tools. Can you talk about how the department plans to enforce the requirements that MA plans comply with Medicare rules and do not inappropriately create barriers to care?
Congressman, thank you for the question. And as you know, we are moving to try to remove some of the layers of of obscurity that have made it very difficult for us to have clear sight on how the MA plans are operating and to have the data that shows how they're administering some of their programs. And so we're trying to make sure that we monitor the way the MA organizations use their utilization of utilization management tools that will ensure us that they are complying with the new requirements that we put in place in regulations. We're going to continue to make sure that if prior authorization is used for making decisions on payment of bills, that we have better sight and we understand what data they relied on. And certainly because of the preoccupation with AI, we want to make sure that algorithms aren't being used that discriminate against communities and populations because they don't take into account the full breadth and scope of circumstances and the data that's necessary to make sure that decisions are being made based on coverage.
And that is exactly what our worry is. Thank you, and I yield back.
Thank you. 209 folks have not voted yet, but we'll go to Ms. Miller. I think we have time for that.
Thank you, Chairman Smith, and thank you, Mr. Secretary, for being here today. West Virginia has the highest mortality rate in the country for patients with kidney disease. I have focused much of my energy on the healthcare space on advocating with patients who have chronic kidney disease, ESRD, and I'm glad to be able to discuss these issues with you in the past. Last year, I led a letter with Congressman Blumenauer about the need for a pediatric ESRD modifier within the ESRD payment bundle, and I was very pleased when your agency took our advice and created one. I'm excited to see how this improves child care, or children's care with ESRD. I also led a letter with Congresswoman Del Bene about the need for Medicare coverage of home dialysis for patients with acute kidney injury. Many patients with AKI are at the beginning of their kidney disease journey, and studies show that almost 50% of the patients with AKI never regain kidney function. Ensuring that these patients have access to home dialysis from the start is critical to helping them remain on home dialysis down the road if they do develop ESRD. Just last week, this committee heard a powerful testimony from a home dialysis patient about the absolute life-changing potential of home dialysis. For these reasons, I'm concerned by CMS's decision not to allow home dialysis for patients with AKI, which does not seem aligned with HHS's overall goal of increasing home dialysis uptake. All patients, including those with AKI, deserve the opportunity to decide, along with their clinical team, what dialysis modality is right for them. How are you working to ensure that CMS policies around AKI patients are aligned with HHS's overall goal of increasing home dialysis?
Congresswoman, thank you for the question. And by the way, thank you for your deep work on this issue because for many folks, and it's not a large community, this is life and death. And so thank you for the work that you're doing. We're talking about, we have to make sure that when we're extending access to some of these services through the Medicare or Medicaid programs, that we do it right because taxpayer dollars are involved. We have to make sure that we're focusing correctly. On this particular issue, we've been taking comment from the AKI community, and we will continue to do so. I will take back your comments today to our folks at CMS so we can follow up with your team if you'd like. We're not done, and this is an issue I know you're not going to stop working on, and we'll try to get there because what I think we all understand is that at the end of the day, the quicker and better we get services to these families, the less it's going to cost taxpayers.
And I do appreciate your commitment to kidney disease patients, and I thank you for working with me. In West Virginia, about half of Medicare beneficiaries receive coverage through Medicare Advantage. Your department recently cleared a CMS rule that is waiting for White House approval that would overhaul the Medicare Advantage enrollment process. This committee's been engaged on this issue. 14 members, including myself, sent you a letter on January 12th on the proposed rule. Like you, we are concerned about bad actors and aggressive marketing practices that cause headaches for seniors. We also believe seniors need resources to decide which plan to enroll in, but your proposal would limit resources in the enrollment market for everyone, not just bad actors. Would you commit to me that CMS will not reduce enrollment resources nor limit the ability of agents and brokers to help beneficiaries find Medicare Advantage plans that do fit their needs the best?
Congresswoman, let me commit to you to work with you on that issue. Now, one of the concerns we have is that we want to make sure that people are steered to the plans and services they need, and we want to make sure that at the end, it is in the benefit of a patient that they end up in a particular type of plan or service. So more than willing to work with you to address that, because I think you and I both have the patient's interest most in mind.
Thank you. Mr. Chairman, I yield back my time.
Thank you. We are needing to recess, Secretary. The committee will recess now and reconvene immediately following this vote series. Committee will come to order. Dr. Murphy, you're recognized.
Well, thank God. Thank you, Mr. Secretary, for coming back. Sorry for the pause. I just have to say one thing. I think some folks are tone deaf around here. You know, I'm not a big fan of private equity in healthcare. I think it's horrible in healthcare personally. I think they're driving things out. But that's not the reason why we can't put nurses in nursing homes. We don't have the nurses. You know, we have closed beds at my institution, at my medical center, because guess what? We don't have the nurses. I'm fine if we work on some program to get nursing homes up to par. I believe it's absolutely necessary, but you can't make them out of thin air. You can't make them out of thin air. And I would urge you to postpone this until we actually can we can reasonably do this.
Congressman, would you like me to comment?
Sure, happy to.
Yeah, I don't think families can wait until a facility says they can find a particular.
Mr. Secretary, how are you? Again, I'll go back. It's tone deafness. If you don't have the nurses, how are we going to put? I agree with the problem. You and I agree on that.
But Congressman, are you saying that they don't need nurses in a nursing home?
No, I'm not saying that at all. Please don't try to change my words. I'm not saying.
I'm not. I'm just trying to
saying
figure out how you
could. There are not enough nurses in this country.
But how can you then say that you have enough beds, you have enough people to provide quality care to someone if you don't have the personnel that really can provide the quality care?
Well, then, I mean, again.
Is it inferior care that people are supposed to accept?
No. But again, I'm going to go back to the fact there are not nurses. We can't pull them out of the air.
But then how do you call yourself a nursing home?
Because that's what it's done. You don't have a nurse at every bedside.
No,
Yeah, you're rewriting all right, let's move on to more issues. You and I are not going to agree with that. I can't go poof with a magic wand and turn these things out. Let's turn out to another debacle, and that's surprise billing implementation. I am so glad after 4 lawsuits, 4, we actually got the day. Now, here's the problem. Things have been adjudicated, but insurance companies aren't paying people. Mr. Chairman, I'd like to submit to the record 3 examples, one from a NICU, one from an emergency department, one from anesthesia for spinal services. These people have been adjudicated, were supposed to be paid, but our insurance companies still don't pay them. One about to 2 years. They've been adjudicated and not receiving their payment.
Without objection.
All right, Mr. Becerra, can you tell me how many times has HHS leveled this $10,000 monetary fine against insurers who are violating the coverage protections?
Congressman, I don't think I have that particular information with me, but I can get you that information.
Can you take a guess?
It wouldn't be worth it for me to take a guess.
My question is, are we doing this at all? I think, you know, I'm going to go on a Medicare Advantage rant here in a second. I think we're really protecting our insurance companies way too much. I would like to know that information, hopefully by the end of next week, how many times the department has levied that fine.
Let me try to get back to you as quickly as we can.
All right, thank you. I think we have shared interest, bipartisan interest, in what I think the debacle has become in Medicare Advantage plans. I think it was incepted with a very, very good idea to try to deliver more personable, more expedient care in a more efficient system. But just like our pharmacy benefit managers, they've gone awry. We now, as my understanding, we have MA plans that have received tens of billions of dollars of overpayments. Is that your understanding?
There's clearly signs of overpayment. I won't categorize the dollar amount.
You know, this is critical because, you know, when you pop up Joe Namath on the television, everybody feels good about it. And I want our seniors to have care, but when we're adding 10,000 seniors to the Medicare rolls every day, and we're not providing them with care, my system, which we have 74% government payer. Our margin is razor thin in delivering care. We've decided to stop taking Medicare Advantage. We have to fix this system. We have to reform the system. And I'm very disappointed that we're not being presented now with a plan, even an offer of a plan to fix the disaster that's going to happen with Medicare.
Congressman, we have just published rules to try to provide reforms. I will tell you that We are prepared to continue those reforms. We continue to receive letters from your colleagues saying we're going too far.
I'm happy to work with you. I know there are many things that may not be as conservative as people want, but when we're having the pyramid flipped upside down on who's paying into the system, the age right now, we're seeing SIPT at 65 before, and now we're having 4% of our individuals live into their early 90s. The numbers just don't work. We have to fix that system.
And I know you know what you speak of because you're in this field. Very much would look forward to working with you on that.
Excellent. Thank you, Mr. Chairman. Yield back.
Ms. Sewell.
Thank you, Mr. Chairman, and welcome, Secretary Becerra. Today, I'd like to spend my time talking about two topics that are really important to my constituency: expanding advanced premium tax credits and continued support for rural health providers. I am proud of the Biden-Harris administration for taking the necessary steps to close the coverage gap in this country. As a representative of Alabama's 7th Congressional District, a district with high rates of chronic diseases, yet in a state that has not expanded Medicaid, closing the coverage gap remains a top priority for me. The advanced premium tax credits were established by the Affordable Care Act, and thanks to the American Rescue Plan, more Alabamians can benefit from this tax credit. Prior to APRA, the consumers with household incomes above $400,000, 400% of the federal poverty line were excluded from qualifying for these tax credits. But in 2023, almost 240,000 Alabamians enrolled in the marketplace health plans received the tax credit. This means that more citizens in my home state, which did not expand Medicaid, can afford health care. This is really unprecedented and necessary in states that did not expand Medicaid. So my question to you, Mr. Secretary, is with the advanced premium tax credits being vital to reducing the coverage gap, is your agency committed to working with Congress to expand and extend this subsidy expansion beyond the 2025 timeframe?
Congresswoman, that's a priority of the President's, yes.
Absolutely. I also remain committed to supporting the hospitals in my district. I applaud the Biden-Harris administration for the new option available to support rural hospitals through rural emergency hospital conversions. Just Monday, I spoke about the challenges of access to emergency medical care in my district. Issues from hospital closures to low ground ambulance reimbursement rates have really caused a problem all across this nation, and it was just exacerbated during the COVID-19 crisis. So, Dr. Becerra, can you share how the new rural emergency hospital designation has been helping rural hospitals provide emergency care? And beyond the $5 million in technical assistance, how is your agency helping to expand this designation in communities across this country?
Congresswoman, the new designation, it becomes very important for rural emergency hospitals because it gives them enhanced support. We know that if some of these facilities are going to survive, we're going to have to do something differently because they provide that critical care, and it's oftentimes very expensive care, and it's not something that a facility can rely upon having at all times. So it's a very difficult financial proposition for a lot of these facilities. We're hoping that this new designation, rural emergency hospital, will help them survive in a place where if they were to go, then families would really be in a hurt.
Not just families, whole communities really depend upon these hospitals. So I wanted to say hats off on this designation and do everything you can to try to expand that. Thank you. I yield back the balance of my time.
Mr. Kustoff.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for appearing today. Mr. Secretary, if I can, last year in the hearing to discuss the President's fiscal 24 budget request, you were asked about the FDA's decision to change the REMs for mifepristone to no longer require an in-person visit to a medical professional. Now, I wrote down that part of in your answer, you said, quote, you don't just get access to it because you want it, you still have to have it prescribed. And you were referring to chemical abortion drugs like mifepristone. My question is, there are websites where users can purchase chemical abortion drugs delivered to their doorsteps, in many cases without a prescription. There's a website called plancpills.org runs a page, and it's called Where People Get Abortion Pills in Tennessee. I represent the 8th Congressional District of Tennessee. When you go to that page, there are 26 external websites, quote, for people who want abortion pills by mail without consulting a clinician. Now, some of these sites, lifeeasyonpills.org, bestabortionpill.com, abortionease.com, drugs99.com, homeabortionrx.com, and it goes on. So I've got two questions for you, Mr. Secretary. One, is the FDA and HHS keeping track of websites that mail these untested pills to Americans? And my second question is, will you commit the FDA resources to warn the American public of the grave risks posed by the use of chemical abortion drugs acquired through unauthorized websites?
Congressman, thank you for the question. I won't presume to speak specifically for the FDA in how they are conducting some of the work that they're doing. We consider them a very independent agency, but what I will tell you is that anytime drugs are put up for public consumption that do not abide by the standards set by the FDA, we have to make sure every American understands that they're taking major risks. And the FDA has the authorities to do enforcement activity, and I know they are trying to keep pace with a lot of this fraudulent activity that is occurring. And what I can do is get back to you on it specifically what FDA is doing in this regard. But no doubt we have to make sure people understand you are putting yourself in peril if you try to purchase some of these medicines that are not officially available.
And without a prescription, right?
And without a prescription.
And just so everybody knows, the chain of command, everybody who's maybe watching this hearing, the FDA is an agency under HHS, correct?
Yes, it is.
You've got ultimate authority over FDA.
Ultimate authority in most cases, but because they're a regulatory body, we give them a great deal of deference so they can make regulatory decisions without interference from other sources.
Fair enough. What these websites are doing, at least the way I described it, it's not lawful, right?
The way you've described it does not appear to be lawful.
Okay, and I realize you've got to accept what I'm saying. If I'm right, shouldn't that require from you a referral to law enforcement to investigate these things and maybe shut them down so that they don't distribute these drugs, which may or may not be tested, and certainly that are being dispensed without a prescription from a clinician?
And Congressman, as I said, I know that FDA tries to get on some of these cases as quickly as it can. You could probably imagine how many vaping manufacturers are out there trying to sell products without the right, actually, in most cases, vaping should not be available out there. And it's difficult to keep pace with all that's coming out, especially on the internet. But I could try to get back to you to let you know precisely what FDA might be doing.
Well, doesn't it seem ripe, R-I-P-E, for the Secretary of HHS to refer these type of activities to federal law enforcement?
I'll make sure that, because, again, remember, FDA's enforcement powers will differ from what local law enforcement powers.
I got it. I'm a former federal prosecutor. Shouldn't you be referring these websites and the other dispensers to federal law enforcement?
If you wish to give us that information that you have already tracked, we would more than be willing to make sure we provide that to the appropriate authorities.
I've just given it to you, but we'll send something else to you, and I
It'll help
do
to have something in
appreciate a
writing.
response.
Thank
you, Mr. Secretary. I yield back.
Thank you very much.
Thank you, Mr. Stubbe.
Thank you, Mr. Chairman. Mr. Secretary, your department has cleared a CMS rule that is waiting for White House approval. It would overhaul the Medicare Advantage enrollment process, undermining the integrity of the program and pushes us closer to Medicare for all. In my district, I represent a constituent with nearly 20 years of Medicare experience who has served over 250,000 people who said of your agency's push, and I quote, "The proposed rule will harm the most vulnerable beneficiaries because they are dependent on support to access the ongoing health services they require for their own well-being." In the contract year 2025 Medicare Advantage and Part D proposed rule, CMS proposes certain changes to agent and broker compensation for enrolling individuals in MA plans. The proposed rule has implications for Medicare beneficiaries, field marketing organizations, or FMOs, and agents and brokers who all play important roles in helping seniors select and enroll in the MA plan that best meets their needs. The HHS proposal would limit fees in the enrollment market for everyone, not just the bad actors who are aggressively pressuring seniors to sign up for a plan. This committee has been engaged on this issue. I led a letter with a majority of Republicans on this committee to CMS trying to get clarification and answers. Unfortunately, your agency sent the rule to OMB for final review before responding to our letter, almost 2 months later, with a less than satisfactory response. Mr. Secretary, are you familiar with the letter that we sent to CMS?
I believe I am.
So you've read it?
I believe I'm familiar with what it says. I couldn't tell you that I had a chance to read it in the recent past.
It's signed by myself, Mr. Buchanan, Mr. Adrian Smith, Mr. Kelly, Mr. LaHood, Mr. Winstrup, Mr. Ferguson, Mr. Estes, Mr. Hearn, Mrs. Miller, Mrs. Tenney, Mrs. Maliatakis, Ms. Van Dyne, and Mr. Carey. Are you familiar with the response letter that we received from CMS?
I believe you just received it not long ago, right?
It's dated March 1st, 2024. Have you reviewed this?
Again, it would have been a while ago.
Well, it's only like 20 days ago. So you don't remember reviewing the response from CMS?
Congressman, a lot of things happen in 20 days.
Well, I mean, you were coming to this hearing and you had a letter to CMS, which it's the agency underneath you, right?
Congressman, I'm going through a whole lot of stuff. What I'm telling you is I do recall the issue. Can I tell you that I read it in the last day or so? I can tell you for a fact, not in the last day. I know I have been briefed on this issue.
Okay, Mr. Chairman, I'd like to add to the record both our letter, which is the majority of the Republicans on this committee, and I'd also like to add to the record the response from CMS.
Without objection.
Do you know why CMS didn't respond to us, the Committee of Jurisdiction, before sending the rule to final review?
Congressman, the process that CMS undertakes takes quite a while. That you would have known the process was underway.
Right, we sent the letter January 12th.
Our process would have begun way before then.
So your answer is you don't know?
No, I'm telling you that we began a process. We engage with members of Congress as they reach out to us.
Right, this is the Committee of Jurisdiction, correct? And you had the majority of the majority on this committee send a letter to CMS, and I'm simply saying, why is it that you guys sent the rule to finalization before responding to the Committee of Jurisdiction's majority?
Congressman, remember that the fact that we send the proposal to another interagency within the federal government doesn't mean it's done, that there won't be any changes that are made.
You sent it to the White House at this point. Okay, well, the response letter we received from the CMS administrator says, and I'm quoting, "The proposed single compensation rate is based on calculations that we described in detail in the proposed rule." I just reviewed the letter again. It's not detailed in the proposed rule. There's barely anything there, and CMS is proposing a $31 cap for these services. Do you believe that $31 is a fair amount for these services?
Congressman, what I can tell you, what I recall is that we're trying to avoid having incentives that would have a broker or dealer direct patients to a particular type of plan over another, which may not be the best in the best interest of a patient.
Yeah, but as I just described, there's a ton of other very good businesses out there that are providing services to my constituents and everybody else on this committee to put them in the right plan.
Well,
so what I'm asking you is, do you believe that the $31 that's in this rule promulgated by CMS that you approved is a fair amount?
I believe the rule tries to attack a problem of having patients being referred to particular plans not because of the
But
best
you can't use a
plan.
sledgehammer for a needle.
Oh,
Like that can't be the approach. So I'm just simply asking if you think $31 for what these people do is a fair amount.
Again, what we're trying to do is prevent steering of patients into plans.
Do you know any of the services that are provided by some of these organizations?
I'm sorry?
Do you know any of these services that are provided by the FMOs?
Do I know?
That you're now putting $31 as the amount that they do?
Are you talking about the
I have
broker?
5 seconds left, so I'll give you examples. IT, infrastructure, logistics, human resources, marketing, partnership, broker training support, beneficiary enrollment support, compliance, retention, leadership and management, which a number of these individuals rated about $615, and the rule is saying $31. I just think that this needed to be addressed. You had members of this committee that were concerned about it, and we were basically ignored for 2 months, and they promulgated the rule anyways. And I would expect that the Committee of Jurisdiction would get a little bit more respect, especially from a former member of this committee. I yield back.
Ms. Moore.
Thank you, Mr. Chairman, and welcome, Secretary Becerra. I think before I start asking you some questions, I want to clear the air on a couple of topics that have come up from Mr. Smith and Mr. Buchanan regarding no TANF for people above 200% of the poverty level. You said you were taking comment on that, so I'm going to give you comment. I do think that the framework for TANF was to respect flexibility, and although the quarterback, Brett Favre, and folks misused it in Mississippi, I do think that retaliating against the fund and people who need it is the wrong move. So that, you know, taking $5 million a year from the contingency fund, I think is wrong-headed. I think it's wrong-headed to say that you won't serve anybody above 200% of the poverty level. You know, when you start thinking about the kinds of things that you say you want to do under TANF, you know, some TANF monies is used to supplement the EITC, the state child tax credit. And so before you fall into the trap of my colleagues on the other side by nodding your head to that, I would want you to think that through. I was really pleased to see that the budget was addressing mental health and substance abuse problems. Once again, I have a bill that would provide perinatal mental health and substance abuse problems for pregnant women from the earliest stages of pregnancy until 1 year afterwards. And I think that you don't want to upend that with some sort of agreement about 200% of the poverty level. So that's my comment on that. And with regard to drug testing, TANF recipients, I say that, you know, I'm not a lawyer, so I don't know much about the 14th and 15th Amendment and due process and equal protection and stuff. But I know that if you're going to just pick out people who receive TANF, there are a lot of people who receive entitlements in our country, and you're not drug testing them. So maybe we should expand the list of people who receive monies up to and including some very wealthy people who receive tax credits and tax benefits. That being said, let me ask you some questions I intended to ask you before their testimony. I was really interested in understanding how HRSA, the HERSI opt-in modernization program, whether or not that can fill the gap in access for people of color to be able to access deceased and be included on the deceased donor transplant list. Will this help to decrease the disparity?
Congressman, I apologize. You're going to have to repeat the question.
All right, I'll ask another question. How about the Medicaid unwinding? There are 12 million people out there who do not receive Medicaid because of procedural reasons. And so is there anything that your department is doing help with the states to do outreach to these 12 million people that lost Medicaid?
Congresswoman, since before last year, we started working with governors and states about the Medicaid unwinding process and making sure that as they go through the redetermination process, that they're making sure that for bureaucratic reasons, people aren't kicked off of indispensable.
Well, they are being kicked off. So is there any effort to make sure we contact and reach those people to get them back on?
Yeah, we've engaged in a number of the one where we were able to get 500,000 to 600,000 kids back onto rolls because we found that the states were not applying the procedures properly.
Okay,
one of the methods.
Thank you. I don't have much time. I have legislation to reduce the tax disparity affecting the health professionals who receive the Indian Health Services scholarships. So does your budget, which does a lot for Native Americans, address the tax gap between Indian Health Service scholarship recipients and others?
Gosh, I'll have to get back to you on that one.
Okay, thank you. Let me ask the question that you didn't hear before. There's a big disparity in organ transplantation for people of color and other people. The HRSA opt-in modernization, is that going to help people of color access the donor list?
The whole purpose behind the reform and the legislation that recently passed is to change the dynamics so a monopoly doesn't run the system, and it's done on a more competitive basis, and the system that's in place to make sure who gets transplants is done fairly throughout the country is now going to be done without profit or other motive involved.
Okay, just one final question. The principal illness navigation, the PIN, for cancer and stuff, do you think that the kidney transplantation would benefit from this PIN navigation system?
Congressman,
is that a possibility?
You're going to win the prize for giving me the hardest questions to answer that I wasn't prepared to give you a direct answer to. So let me get back to you on that one as well.
Thank you so much, and thank you, Mr. Secretary, and thank you, Mr. Chairman.
Thank you, Ms. Tinney.
Thank you, Mr. Chairman. Thank you, Ranking Member.
Ms. Tinney's right after you, Ms. Moore. Yeah, I didn't call you Ms. Tinney, but thank you.
Are we ready? Thank you, Ms. Moore. I always love hearing your testimony. Thank you for the great questions, for really putting the Secretary on the hook. I appreciate that. You always do a great job. Thank you, Mr. Secretary, for being here. Obviously, it's very important to have you here. And I know many of us are, at least on our side of the aisle, are concerned about the Department of Health and Human Services FY25 budget request and some of the political priorities that seem to be permeating this budget over the needs of the American people. And I want to just kind of jump into some of the questions. My first one is the co-chair of the Election Integrity Caucus says, in response to President Biden's executive order, it's 14019, I'm not sure if you're familiar with it, your department has announced that it plans to turn more than 1,400 community health centers into voter registration hubs. Implementing this policy will require these essential safety net providers to take their focus off rural disadvantaged communities they serve on and to get involved in political activity. And you just cited to Dr. Murphy that we really have to be focused on our core mission, which is the mission of providing health care and good health care to our communities. Do you think it's appropriate for the federal government under this executive order to be engaging in electioneering or these vote harvesting types of drop boxes and political activity while they're doing their official jobs as members of the Health and Human Services?
Congresswoman,
government payroll.
Thank you for the question. Those community health centers cannot engage in electioneering. That would be a violation of federal law. And simply by providing people with access to information so they could register to vote is not a violation of federal law.
How about providing, having staff have to monitor drop boxes and other political entities that are there? Is that something that the people from Health and Human Services would be doing at this election coming up?
What you've just described does not sound anywhere near what the job would be.
But the executive order specifically asks federal agencies to engage in this type of political activity. Is that something you're going to prohibit as the secretary?
I think you've inaccurately described it, but if you have the executive order and read me that, I could tell you what it means, but
it's 14019. We've talked about, I mean, it's on my, you can go to my website, tenney.house.gov. I explained my votes there too, but let me move on because I think it's really dangerous for our federal employees who are on our government payroll to be engaging in electioneering.
They can't
to
do
the
that.
extent,
it would be a violation of law.
But somebody's got to monitor and make sure we have election integrity there. So I assume that, who's going to be monitoring this other than maybe some of our, I just want to be sure that you as secretary are making sure there's a wall between the people who are serving the public for healthcare reasons and those who are engaging in political activities.
We make it clear to all of our employees.
Will you be doing that to make sure that happens?
We always make it clear to them that they cannot engage in activities that cross the line.
Including what would be under Executive Order 14019.
That's where I disagree with you. I don't believe there's any electioneering that would be done by federal government
Do
personnel.
you think a drop box is something that, who monitors a drop box at a federal agency?
As I said, if you show me what you're referring to in the
We'd be happy to provide that with you. I want to get to the next question. So I know that the administration's, I want to just ask you quickly a question. It could be your personal view or it could be the view of the administration that you serve. Do you consider yourself, when it comes to the issue of abortion, as pro-choice?
I'm here testifying as the Secretary of Health and Human Services. I have a pretty long record about where I am personally, but I'm here today as the Secretary of Health and Human Services. So I would answer the question, if you'd like, as the Secretary of Health and Human Services.
That'd be great, yes.
And so I would answer you by saying that we provide every type of health care service available to the American public. We'll protect every American's right to access the health care that they're entitled to under the law.
So
That
if a
includes
woman
abortion
wants
care.
to choose to have a baby, that service is protected as well?
Every service that a person is entitled to under the law, if we have a role in providing that service, we'll make sure that that right is protected.
Thank you. I greatly appreciate it, because under your leadership, HHS is expected to finalize a rule that will block crisis pregnancy centers from receiving temporary assistance for needy families, otherwise known as TANF funding. These pregnancy centers are dotted throughout the country that do provide pregnancy testing for sexually transmitted diseases, prenatal, pregnancy education, ultrasounds, adoption referrals, and a number of items for needy families. And TANF is about keeping families together, I assume. So I want to make sure that you are going to make sure that, why isn't this rule covering crisis pregnancy centers if indeed you are looking for access for all families and all choices they make, whether they choose to have the child or choose the abortion route?
Congresswoman, I think you've mischaracterized what the rule would do. So long as entities qualify to receive the money and will be providing the services that are required by the statute and regulations, they will receive their monies.
So, but it specifically prohibits crisis pregnancy centers from receiving that money?
No, it doesn't. It prohibits anyone that is not providing the services that they're obligated to provide if they want to receive the money.
Thank you. I appreciate it.
Mr. Fitzpatrick.
Thank you, Mr. Chairman, for holding this hearing. Mr. Secretary, thank you for being here today. During the 118th Congress, my office has submitted approximately 160 individual cases on behalf of my constituents to HHS, specifically regarding their Medicare coverage. And this is a period of just over 1 year now in this Congress. Just yesterday, a constituent of mine who has diabetes contacted me regarding Medicare's inability to address payment processing. Her insulin pump is covered under Part B, yet she was presented essentially with only two options. Number one, wait until the end of the week and hopefully the payment processing issue would be resolved, or she could pay $300 for traditional insulin, which her Part D plan clearly does not fully cover. As you know, Mr. Secretary, insulin is it's a life-saving drug for diabetics, and expedited back-end payment processing is essential for those that rely on receiving insulin in a timely manner. So my first question, sir, if you could just share with us what HHS is doing to speed up this payment processing, because this does have a real impact on people's lives and it can become a very frightening experience for them.
Absolutely. And Congressman, let me begin by first saying, if you'd like, we can be in touch with your staff, because if your constituent is still having issues, we have had conversations directly with the payers, the various insurance companies, and we have a contact for them, so that if there is an issue for that provider being able to provide a service, that we can get that provider connected with the payer so that there is no delay.
That's great. Thank you.
So we'll work on that with you, but just to give you a sense of what we've done, immediately we started working with United Health Group to try to understand what they were going to do to make sure payments did not stop, even though the billings were not coming across the threshold. We are also trying to make sure that every other payer, because many of these payers, as you know, receive Medicare and Medicaid dollars, so we've already paid them. The federal government has already given them money for the services they're going to provide, and yet they're not paying for the services that these patients need. And so we're trying to make sure that they show us what they're doing to make sure payments will occur, even if in advance, and then you reconcile the differences later. So far as Medicare and Medicaid, we have made sure that nearly 6,000 doctors, hospitals, and other providers are able to receive from Medicare advance payment. So far, the total that we've put out to these providers, doctors, hospitals, and other providers, so far is over $2.5 billion.
Okay, thank you, sir. I also want to use the remainder of my time to talk about the recent cybersecurity attack. Obviously, numerous medical practices in our community have reached out to us. These cyber attacks, as you know, sir, have the potential to impact billing and cash flow, Medicare submissions, eligibility checks for patients, and impact transmission for electronic prescriptions, many of which are heavily relied on by people across the country, particularly our seniors. Given the already existing constraints on local practices that they're facing, like cuts to Medicare reimbursement, high inflation, labor shortages, and the like, including overall payment delays, can you share with us, HHS's plan to address those pressing concerns that our constituents are facing?
So if the question is on cybersecurity and how we move forward, we have put out a plan, and it's open for comment. We're subject to comment and further discussion. What we believe is that everyone in the sector has no choice but to, get with it, understand that you can't leave your security doors unlocked. You got to close those doors from cyber attack. And so what we're suggesting is that we are willing to put it, and I believe the president's budget has about over $1 billion, $1.2 billion to help providers begin to transition to greater cybersecurity. But after a point in time of providing support, essentially carrots, to get providers to, amp up their security, at some point, we're all going to be in danger if somebody doesn't. So we want to make sure everyone has done something. So first, we're providing support and incentives. But after a while, if you haven't done what it takes to protect not just yourself, but everybody who depends on you, then you're going to have to start paying a bit of a price for not having joined the rest of the team.
Got it. Thank you, sir. I yield back, Mr. Chairman.
Mr. Beyer.
Mr. Chairman, thank you very much. And Mr. Secretary, good to have you here. I want to just add my voice to the concern about the new TANF rule, specifically about high school dropout prevention programs. Some of the most important ones around the country, Jobs for America's Graduates and others, rely on TANF funds to pay for it. And the argument, of course, is better to people that don't need to go on TANF in the first place. And I hope that you and your folks will pay attention to that. What we'd like to do is ultimately reduce the overall TANF burden. And it's the old pay me now or pay me later piece. I also want to thank you and applaud your dedication to suicide prevention and mental health. It's really important that we adequately fund the 988 number, the CDC suicide prevention effort. I believe there were 507,000 calls alone in the month of January. It's making an enormous difference. And I also want to applaud you for your work on long COVID. It's still we've done a lot. Last week we had Long COVID Awareness Day, but we still don't really understand post-illness acquired conditions, and now is the time to ramp up for the lessons learned. President Biden is leading on the AI revolution, and I know you've testified its consideration in your budget. You've been using artificial intelligence in healthcare, the FDA specifically, for years. But can you talk about what gaps you see in your existing regulatory authorities and funding when it comes to supporting AI innovation in healthcare?
Congressman, great question, and thank you for the work that you've done on this subject. We don't have enough authority to really go in and see behind the curtain of what's going on with a lot of these entities that are using AI. We'd like to make sure, for example, that the algorithms that they're using won't end up discriminating against people because the data they're using to input into these algorithms don't take into account the needs of particular communities. We'd also like to make sure we have a better sense of how they're going to deploy some of this AI technology, because it could be done in a way that, once again, it leaves out certain communities if they don't happen to fit the criteria or the perspective of that particular algorithm. AI can be a tremendous asset. It can help produce efficiencies, accelerate access. At the same time, if we're not careful, it will do it only for some but not all Americans. And so our interest is being able to look behind the curtain to make sure that the platforms that are being used have equity in them from the very beginning.
Yeah, very good. Thank you very much. There's a lot we can also learn from the electronic health records conversation with respect to AI. And one of the ideas has been an assurance lab, which I know the FDA Device Center Chief's been considering. Can you talk about if this is something HHS is seriously pursuing, the whole notion of assurance labs?
I'm going to tell you I'm not as deep on that as I should be, and what I could do is get back to you and make sure the team responds well from HHS.
I also want to say, on the negative side, we're still disappointed at the continued underfunding of AHRQ ARC. It's a really important part of your HHS piece to get the quality right to begin with.
I got to give you a hug, Congressman, for saying that, because you're absolutely right. They do some tremendous work.
Thank you. And finally, on CMS data concerns, the research community has talked to us about CMS has announced changes to its research identifiable file data and the discontinued delivery of physical data extracts.
we're hearing that they could be incredibly damaging to public health system research and health research at large. The Virtual Research Data Center, all caps, has significant coding limitations, it's slow, has regular system errors, interoperability limitations, among other things. And apparently there's significant new fees to access that can run tens of thousands of dollars per researcher, per year, per project, with no option even for having screen sharing among researchers in the same project. Can you talk about how HHS and you can address the access and affordability? What makes VRDC usable in the first place?
Congressman, you've touched on something that I think will become a very important subject to resolve, and that is that data is so valuable, and for researchers, it's gold, and we want to make sure that researchers have that information that they need so they can continue to come up with innovations and therapies that will keep people alive. At the same time that we know, as we saw with Change Healthcare, that there are bad actors who are constantly trying to get access to that same data and use it for the wrong reasons. We have to make sure that everyone who accesses data, and we provide a lot of data, that it's not misused. And so we're just doing what everyone is now having to do, is moving toward platforms that provide more security, because you don't want your personal data, I don't want my personal data to get to go into the wrong hands. If it's a researcher doing the right thing with it, great, but we don't know, and we have to live in this new world. That's why we're migrating to something that provides more protection, but we'll continue to take comment because we've heard these concerns, and we want to make sure at no point do we stifle research.
Thank you very much, Mr. Secretary. I yield back.
Thank you. Ms. Still.
Thank you, Mr. Chairman, and it's so nice seeing you, Secretary Becerra, for long hours. Thank you. You're staying testifying. Last year, I asked you about hospice fraud. You know California so well, and why CMS was still certifying new hospices in California. You said during the last hearing, you will not abreast of what the state of California is doing. I have few articles here that I'm going to submit on the record that new hospices cropping up in fraud hotbeds amid ongoing program integrity push. Hospice fraud back in the spotlight with new data also raising questions about the home health care. California Hospice Network state falls short in curbing potential malfeasance. Medicare certifies hospices in California despite state ban on new licenses. These are all the articles. We can find more, but you know what? I have 4 here. So my question is, I want to ask you again, why is CMS certifying hospices despite California's moratorium due to rampant fraud?
Congressman, I can make sure that we give you a more complete answer than what I can give you right now, but what I will tell you is that there are programs in place where if the applicants go through the process and certify to CMS that they have a program that will service the needs of a community when it comes to hospice care, and they are able to meet the standards, that we will certify them to be able to provide hospice care. That then some of them go out and do things that are against the law or do things fraudulently, there's no doubt that's one of the reasons why under Medicare or Medicaid, we are constantly trying to go root out that fraud, and we would like to crack down on it. And so we know that hospice care is growing, and it's going to continue to grow, but we have to have more accountability. Look forward to working with you to make sure we can address that.
But Los Angeles only, CMS certified an additional 98 hospices. You know, we really have to crack down these hospices care, and then we really have to look at it. Last summer, CMS embarked on a nationwide hospice site visit project, and you claim to have made unannounced site visits to every hospice, over 7,000 total, in an effort to catch fraudulent providers. And there are a lot of bad actors in Southern California more than anyone else in the country. So how many hospices have been terminated? And as a result, how many of the hospices in LA County or Orange County, those are where I'm representing, is CMS saying aren't fraudulent? My constituents need to know if they visit a CMS certified hospice, they will take care of them.
Congressman, you're asking for very granular information about Los Angeles County or Southern California. I don't have that before me. I can make sure our teams respond to those questions in particular. But what I can tell you is that we are, if you look at our budget that the President has proposed, we increased the funding for program integrity to go after that fraud, and we would look forward to your support because we know that there's always someone trying to game the system, and we know that there are people, like my father before he passed, who needed hospice services. And so very much would look forward to working with you to try to make sure we root out that fraud.
And I want to know about those 7,000 hospice care that really visited, unannounced site visits and just took care of it or not. So Medicare beneficiary ability, making informed decisions about their care is one of my top priority. HHS has a tool for the public to review Medicare survey and certification data. The website Qualify Certification and Oversight Report has been unable to provide the information for home health agencies since early 2021 due to a system migration issue. So my question here is, the public has right to know what providers are enrolled in the Medicare program, and it is completely unacceptable that a public-facing website has not been operational since 2021. Can you explain why this has occurred and why the agency proceed with enrolling over 800 new home health agencies in California?
Okay, Congresswoman, what you're presenting to me is something I've not heard, so I'll have to get back to you on that. But I will tell you, just as we talked in our discussion about hospice care or nursing home care, home health care, which is a growing industry as well, is something that we're trying to monitor more closely. We are constantly doing program integrity work in this field as well, and we could try to respond more specifically to any questions you have. But what you've just mentioned does not sound familiar to me.
Thank you. I hope that you will have more conversations. My time is up, and I yield back.
Thank you. Ms. Fischbach.
Thank you, Mr. Chair. And first, I want to correct the record. The staffing requirements proposed in the rule are the same for urban and rural nursing homes. There is a difference in implementation timelines, but the requirements are the same. Thank you very much for letting me just correct that. But I know that we've talked a lot about the nursing home staffing ratio issue, and various questions have been asked, but I guess I'm really wondering, do you plan to finalize the rule? And if so, will the final rule be responsive to the thousands of comments that you've received? Thousands from nonprofit nursing homes that oppose it. And have you reached out to any of those stakeholders to try to improve this and make it work? So will it be responsive?
Congresswoman, we absolutely have reached out. We've had many listening sessions with any number of the stakeholders. We received, as you're aware, thousands of comments. We are the reason we're taking some time to finalize the rules because we're trying to respond to all those comments as well. So absolutely, we will take them into consideration. And I must disagree with you. There is a distinction in the treatment between rural facilities and urban facilities, whether it's only because of time or the hardship exemptions. Smaller facilities, facilities that are in very difficult circumstance have hardship exemptions that they can apply for as well.
Well, but I want to know, okay, so you said you've had stakeholder meetings. Have you changed the rule? So you can have meetings. I can have meetings, but that doesn't mean that anything, the rule and the issue that we're dealing with is going to reflect the concerns that they've brought forward, because they're serious concerns.
I hear you. And now you're asking me to tell you what we're going to do. I can't do that until the final rule were to come out. It would be a violation of our laws to disclose what we're doing. But I will tell you this. We have had several sit-down meetings with the nursing home facilities, the representatives of nursing home facilities, to discuss this with them, along with other stakeholders. And we're absolutely taking into consideration their and others' comments.
Well, I am concerned when you say taking into consideration, the original thoughts on it with the nursing staffing ratios were not good, and so I don't know necessarily if you saying that you're taking it into consideration gives me any comfort that it will be sufficient. I mean, because and I don't think.
I appreciate what you're saying.
And I don't think from some of the comments that I have heard and from some of the responses to things, I don't think you understand the seriousness that what it will do to rural nursing homes, and we can't find enough staff now. And you can come back and say, you can make comments, snide comments to people, but it doesn't solve the issue.
Congressman, I hope they don't sound like snide comments. I'm simply saying there are problems, there are real challenges in the nursing home industry. And it's not something that we can just ignore, because if we do, chances are one of our loved ones is going to pay the price.
Have you looked at, I mean, so you said the only answer you have is to increase nursing staffing?
No, there's
and they
much
can't-
more.
Okay, well.
There's much more.
Then they're better, there should be.
Yeah, there's much more.
Because you can't just say that that's the one answer, because that will shut them down. I mean, it will in rural areas when they can't get enough staff.
But Congresswoman, can I ask you a question? If a nursing home is saying, we cannot find the staff to do the work, does that give you a comfort level that the services that are being provided to the loved ones who are there is sufficient?
There are already nursing staffing ratios.
And you're saying that those are sufficient?
They're already there.
And you're saying that those are sufficient?
I can't say that in every case. And that's the kind of comment where you're not looking for the kind of creativity or things that we can do to help solve that. You're just going to add more regulation to an industry that is already overregulated, and adding something that's impossible for some rural areas to meet.
I hear your concern.
So please, help us, instead of answering with the kinds of questions that you ask me. I mean,
my obligation is to protect people that use services at nursing home facilities. I have to make sure that
and
they
if
are
those
safe and
nursing
effective.
facilities shut down in rural areas, those people have nowhere to go.
Well,
So that's the option in a lot of these places. So if there was
Congresswoman?
other more creative ways that could be answered, and my time is up, so thank you.
But there are many facilities that are providing care
My time
in
is
rural
up.
communities
My time is
that
up.
are not saying they
res-
cannot provide those services.
All right.
Mr. Evans.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for your time before this committee today and for the work over the past several years of fighting to expand access to health care for Americans and to increase equity for our nation's social service. Earlier this year, the Ways and Means Working Family Support Subcommittee held a hearing on the importance of supporting young Americans aging out of foster care. I'm encouraged that the President's budget appears to have requested for the purpose specifically. I look forward to working with you and improving our nation's foster care adoption. So the question I want to ask, how else is the administration and the President working to end discrimination and ensure that every child can find a welcome family?
Congressman, thank you for the question. And as you know, oftentimes the foster care situation for some of our kids is intolerable. And it's oftentimes because of who they are, or that there are people who are not accepting of who these kids are. And we are making it very clear that the obligation of any foster care program is to first and foremost focus on the child. The safety and care of that child is paramount, and the interest of that child. So if that child happens to be someone, for example, who is transgender, that child's interests come before any other interest that the foster care entity might have, because it is our obligation to make sure that that child is getting the best care available to that child. And so our rules now will reflect that the focus is on the child, not the person who wants to become, or the entity that wants to provide the foster care. It's on the child.
Secretary, yield back, Mr. Chairman.
Thank you. Ms. Beth Van Dyne.
Thank you very much, Mr. Chairman. Secretary Becerra, there we go. Do you recognize this building? It's in Van Nuys neighborhood in Los Angeles.
I
So
couldn't tell you.
CMS is a sole authority in certified hospice facilities, yet there are over 100 unique hospice providers registered at this location alone. It's frightening that that has been allowed to happen. And Mr. Secretary, as you're aware, I raised this issue with you a year ago at our last budget hearing. And somehow, here we are again dealing with the same problems. My staff was looking forward to a long-planned meeting with CMS last week on this issue to find out how this continues to have more enrollment and how we're continuing to enroll other facilities here. And yet, at the last minute, we had a cancellation of the meeting with no other explanation than a scheduling conflict. So I'm here to ask you directly, do you commit to seniors watching this hearing that your agency will prevent them from becoming embroiled in fraudulent hospital schemes that deprive them of needed medical care?
We certainly can commit to every senior who's in need of hospice
Well, I
care, that we'll
appreciate
do
you saying
everything
that.
we can to ensure
So
that they
now
are
I'd
not
like
the
to turn to
victims
the
of
ongoing
fraud.
crisis at the southern border and the response from your agency. I want to follow up with some of the questions that have been already asked. Since President Biden took office, Border Patrol has encountered over 473,000 unaccompanied alien children. Not only has the Office of Refugee Resettlement reportedly lost contact with more than 85,000 of those children, but now we're also hearing concerns that ORR is diverting already scarce foster care resources to respond to the surge at the border, in addition to reports that ORR has failed to properly vet and place these children. Due to this administration's crisis at the border, has HHS assessed the burden that you are placing on state welfare agencies, particularly in states like mine in Texas, that already have high numbers of migrant children?
Congresswoman, let me first begin by saying that you have inaccurately depicted the work that we do, so it's hard to answer.
Well, I'm simply asking, have you assessed the burden that you are putting on these agencies that are already stressed for services?
We provide the service to these children under law that you all passed.
Correct.
that
So
requires
there
the
are a
right
number of
testing.
children, even before we had this migrant count, that were not getting the services that were necessary. And now we're putting on hundreds of thousands additional burden on them. Have you assessed what this is doing to the states?
We continue to perform the work that we're required under
Have
the
you
law.
are you assessing the burden that you're putting on them?
We make assessments of the needs of these kids and make sure that when we do provide.
I would highly recommend that you actually talk to your employees, because when I went to the Kay Bailey Hutchison facility in Dallas when they were there, your employees were so upset with what's going on. They're looking at the border and they're saying, we are sending these kids to places we have no idea what their future is going to be. We know that they have been sexually assaulted. A high number of them have been raped on the way here. And the amount of mental stability that they're going to need in the future, those services are outside of our range. Talk to your people, and I would really hope that you would talk to this administration about what they're doing at the border and how this is burdening not only an already stressed system, but what this is looking at to the future of our youth. I want to change now to a pregnancy center, because I know we've also had some questions on that. In your statement on the budget, you went out of your way to say that you've taken action with what President Biden to expand access to reproductive health care. To quote, the Biden-Harris administration has taken action to protect and expand access to reproductive health care in every way possible. And HHS is committed to promoting access to reproduction health care. But we've talked about the CPCs, and yet I'm confused. If it is specifically a service that the pregnancy centers are not providing, can you tell me what that service is?
I'm sorry, what service are we talking about?
For crisis pregnancy centers, they have been targeted within the excerpt from the proposed rules that states that provide funding for these types of programs, including through entities sometimes known as crisis pregnancy centers, basically have a burden to prove that they meet TANF's purpose. You've called them out.
And are you speaking about the TANF program, or what program are you speaking about?
I'm speaking about the funding for TANF and your restrictions on crisis pregnancy centers. But by the way, specifically it says that they have to prevent or reduce out-of-wedlock pregnancies, but you've already identified TANF as being fine for Planned Parenthood, which 95% of their services are abortion, which obviously to have an abortion, you're not preventing a pregnancy, you're preventing a birth. So why are TANFs Why are you limiting TANF dollars from going to crisis pregnancy centers when you claim that you actually want to have all this freedom of services available for women who find themselves in this position?
And I know time has expired, so I'll try to respond quickly to the question. We restrict services only based on the qualifications of the entity to provide the services that are required by law. If the entity is going
What
to
does
provide,
that mean? What
if I could
services?
finish my answer, that would be
But
really
you're
helpful.
talking in generalities, and I'd like you to be more specific.
So, Congressman,
because all day we've heard you talk in generalities. I'm asking you to be more specific. What specific services are not offered by the crisis pregnancy centers that you have targeted them in your proposed rule?
May I answer your question?
I would hope that you would answer the question, not just give me generalities, please.
So we have an obligation to make sure that when we send out a taxpayer dollar, it is being used for the purposes required by the law.
So again, you're not answering the question.
I am getting to the answer,
Okay.
and what I'm saying is, if an entity is restricted from accessing those dollars, is because they're not providing the services that are required by law. We don't identify any particular entity as not eligible.
You identify, in the excerpt from your proposed rule, you're identifying it.
If they do not provide the services that are required by the program.
What services are they not? That's the question I've asked you now 4 times.
The services under TANF. And TANF is to help
Thank you very much,
pregnancy.
Mr. Chairman. I yield back.
Thank you, Mr. Schneider.
Thank you, Mr. Chairman, and thank you, Mr. Becerra, Secretary Becerra, for being with us. It's always good to see you, and I appreciate you staying until the very, very end. Several people before me have touched on the pandemic crisis that started 4 years ago this month. And I think it's important that we remember our journey through the depths of the crisis to what is really, I think, no other way to describe it, the extraordinary recovery our nation has enjoyed since. Much of it because of the policies passed in the last Congress, 117th Congress, but also the work of the Biden administration. I do want to touch on one lingering matter affecting one of my constituents, and many like her across the country. Janine Morbido stepped up to provide free COVID testing through HRSA's uninsured program, relying on assurances that they would be reimbursed later by HRSA, only to be told last year that the program ran out of money. These people acted in good faith, and yet today they're left holding the bag. Many owed millions of dollars. What I'd like to ask is a commitment that you and HRSA will continue to work with me to help these people get the reimbursements that they were promised.
Congressman, I certainly commit that we'll work with you. The difficulty is, as you know, Congress swept away the monies we had for these programs. It's hard for us to give money that we don't have.
I understand. I know we're trying to claw back the money that others took that they didn't deserve, and hopefully some of that will come in. So I understand the challenges, but I would like to continue to work together, so thank you. Let me shift gears. As you know, pharmacists across our country are safely and effectively providing testing, vaccination, and treatment services for respiratory viruses like COVID-19, influenza, and RSV. During the pandemic, as our healthcare system was stretched to its limit, these pharmacists stepped up and played a vital role in providing the critically needed testing and vaccination services. While most private insurers pay pharmacists for these services, Medicare does not. I joined my colleague Adrian Smith to introduce the Equitable Community Access to Pharmacist Services Act, it's a mouthful, to fix this disparity. Our bill would allow Medicare Part B reimbursement to pharmacists for these services within the state's scope of practice laws. The cost of a hospitalization is far greater than prevention or early treatment, and we should be able to enable pharmacists to deliver these treatments to seniors to help make sure that we're keeping them healthy. My question, Mr. Secretary, is considering our seniors are among the most vulnerable populations susceptible to respiratory viruses, do you think it makes sense for Congress to consider policies that improve seniors' access to the services like the proposal Mr. Smith and I have introduced?
Congressman, we are absolutely prepared to work with you to provide technical assistance as you try to move forward legislation. We do believe that seniors need to have access to the care that they need as quickly as possible and at an affordable rate. So we would be willing to work with you to see if there's a chance for your legislation to move forward.
Great, thank you. And let me shift gears again. Ranking Member Neal, in his opening remarks, rightly touted the Affordable Care Act. Like his state, I'm proud that in Illinois we have record ACA enrollment with approximately 380,000 individuals covered. 97% of Illinois children have health insurance, and enhanced ACA premium tax credits are saving a family of 4
approximately $7,500 a year. As we work to improve healthcare access and affordability, I'm proud of Democrats' work to extend key healthcare benefits like the Affordable Care Act, premium subsidies, as we did as part of the Inflation Reduction Act. Many important aspects of the IRA, such as the $35 insulin cap and inflation rebates, are lowering health care costs for all Americans. Also in the IRA is a policy I helped champion to expand Medicare Part D premium subsidies for low-income seniors. All told, the IRA is saving taxpayers and seniors billions of dollars. That said, I want to focus on another contributor to high costs of medications, specifically pharmacy benefit managers or PBMs. I suspect you would agree that market incentives for PBMs have become misaligned. I helped introduce the Bipartisan Drug Act to delink the fee PBMs receive from the price of the drugs that patients pay, thereby removing the incentive PBMs have to push higher cost drugs when cheaper alternatives are available. The Drug Act would also prohibit PBMs from spread pricing, which also needlessly contributes to the high cost of these medications. I'm thankful that HHS is also considering action to address PBM's role in the drug value chain. Mr. Secretary, can I get your commitment that we can work together to address this issue and ensure patients are getting the best medicines for their needs at the best or lowest prices?
Absolutely.
Great, thank you. And with that, I want to say one last thank you. I want to thank HHS for working with EPA to better regulate ethylene oxide, or ETO, emissions for medical device sterilizers. We had to get to a balanced solution, one that addressed the health concerns of these emissions, but also the health needs of sterilized medical products. It's been a top priority for my community, and I'm grateful that EPA established sensible, strict requirements on ETO emissions to protect public health, but did so in a way that continues to provide the supply chain for sterilized medical devices. And with that, I yield back.
Mr. Moore.
Thank you, Chairman, Ranking Member, Mr. Panetta, for holding this hearing. Secretary, it's great to see you again. Now that you've been through a whole bunch of questions back and forth, we're finally going to get to the brass tacks. We're going to solve the problems.
Looking forward to it.
And as we wrap up your day, that's not just, it's said in jest, but I do appreciate your willingness to show up and dialogue with us. Before I get to my questions, just want to urge the department to closely monitoring the Change Healthcare cyber attack and its impact on patients and providers. I've heard from many providers and health systems back in Utah. This is a big concern for them, and this issue matters, so thank you in advance for continuing to focus heavily on that. Last year, I was proud to co-lead my friend Dr. Wenstrup's bill 1691, bipartisan legislation to establish a robust and meaningful transitional pathway for Medicare coverage of innovative technologies and devices approved by the FDA. Multi-year delays in receiving Medicare coverage impedes patient access to breakthrough products and disincentivizes the already risky investment being made in these therapeutic areas. In June of last year, CMS published its transitional coverage for emerging technologies, TSET, the notice for that. The comment period for the notice closed last August. When do you expect CMS to finalize the TSET notice, and will you commit to providing an update soon on the agency's work?
Congressman, thank you for the question, and I know that this was an important one, and I appreciate the work that you've done. I wish I could give you a specific time frame. You know, this year there's a mad rush in trying to complete a lot of the work that we have, and why don't I do this? Why don't I get back to you to give you a better sense, but I couldn't right here today give you a sense of when that rule might come out.
Do you think, I mean, is this within the calendar year? Do you have a sense for, even just an estimate? And
yeah.
I won't even hold you to the estimate, I'm just...
Yeah, I want to say that we're, you know, it's not just us. There are a lot of agencies that are involved.
Yeah.
And OIRA, the OMB are working through this as well. Probably the best thing is for me to try to get back to you.
So, I mean, there are many, what Utah's trying to do in the healthcare space, and we're even going to try to highlight it, like in this committee, I try to use it as every opportunity, having folks in, like we are all about medical innovation. And you can look at the advancements we've made from particularly medical devices and finding, better ways, less invasive ways to do this. And I'm very bullish on the industry to continue to be able to do this and come up with solutions here. This bill, again, very bipartisan, needs to be prioritized. And so I urge you and your colleagues to take a really serious look at it. So thank you, and we will follow up.
Okay.
So shifting gears, last month I introduced legislation to enhance work supports for Americans receiving TANF. Work supports for TANF. The bill is called the Restoring Temporary to TANF Act, and that would require that states set aside 25% of federal TANF dollars to spend on core work activities, including work supports, education and training, apprenticeships, non-recurrent short-term benefits, work activities, and case management for TANF individuals' responsibility plans. We want a quarter of TANF dollars to be spent in every state for work-related, work development, educational opportunities. Like, I know, I'm learning, a lot more about this place. Been here just over 3 years. And I think if you put this down, it's like everybody would agree with it. And things get tied into one thing versus another, and there's a political time. Like, on the merits of that, 25%, do you think that the administration or the or your branch could be supportive of that effort?
So we have a rule that's been proposed, and we're taking comments on it. I will consider what you've just said as the comments that we will take into consideration as we look at what we've been proposing, at least through the administrative route. Certainly, through the legislative route, you can do far more than we can. What I can do is try to follow up with you in response to some of your questions. But we are in comment period, so I have to be careful what I say and how I say it, because I have to make sure that I don't violate the terms of the comment period, where we are not supposed to give any indications about where we will go.
And with that, in my last 8 seconds, I'll just highlight, this is a sincere effort to make sure we are going to help lift people out of poverty. And we want states to engage. I'm from a state, luckily, that does this type of stuff very well. I would put us up against anywhere. And I want to take those best practices and try to permeate it through the rest of our programs. A quarter of the funds to go towards work development programs to get people back on their feet is a primary motivation. And with that, sir, I yield back.
And Congressman, I could just really comment and say, I appreciate that, because I think I heard a number of good faith efforts on what we should do on TANF, and all of those are going to be considered. We've got our rule. You all may do legislation. Either way, I think we all agree we can reform TANF to make it better.
Thank you, Secretary.
Thank you.
Mr. Panetta.
Thank you, Mr. Chairman. Secretary Becerra, good to see you, not just because it's always good to see a California boy in your position, but it's good to have this opportunity to talk to you about an issue that I consistently bring up with you, and will continue to do it, especially today.
I think I know where you're going to go.
Look, we've discussed in this committee before, in your time as well as in other areas, that California patients and providers are facing serious challenges when it comes to Medicare reimbursement rates, and their failure to keep up with the cost of care, especially in districts like mine in the 19th Congressional there in California. I've asked you a number of times about this issue with the goal of trying to figure out how we can work together to fix it, how this committee, which you were on, can work with HHS, that you're now the secretary of, to bring some relief to the many Americans and Californians that are dealing with this challenge. Now, I recently wrote to the Centers for Medicare and Medicaid Services about the lack of geographic adjustments and the area deprivation index for my district to keep up with the cost of care. I'm pleased that CMS did provide a response, which I appreciated, and they also expressed a willingness to work with my community to address future payments. However, as you know well, Mr. Secretary, they mentioned that geographic adjustments are not up for review until 2026. So my question to you, Mr. Secretary, is, in the meantime, how can CMS help alleviate physician payments? And can you give us an idea, or at least describe some of the tools that HHS has in its current statutory authority, if there are, that can help payments match the cost of providing care in my district?
And Congressman, you always raise this, and you raise it for good reason. And again, both of us being California boys, we recognize that we've got very high-cost areas, and we've got areas that are rural where the costs are nowhere near what they are in some of these other areas. And I believe you probably have Carmel, Monterey, and those areas in or near your district. And just outside of there, you get to Salinas, and it's a far different place.
Exactly.
But as you know, as I've said, and as I suspect our team has told you, that the way the rules are written by statute, it really constrains what we can do. And if we try to push a button here, another button comes out over here. And it is difficult because we have to live by this linear formulation of how you do it. We are absolutely prepared to provide the technical assistance it might take to make the changes to the statutes that address the needs of some of the communities that are impacted by the way we do these formulations for reimbursement. But I don't think I have a good answer for you right now, given the state of the statutes.
One option I've heard, Mr. Secretary, is reforming administrative costs for the merit-based incentive payment system. Are there other administrative costs that HHS can reduce so doctors don't have to spend the resources and the time on paperwork and resources serving patients?
Yeah, I've heard this as well. And certainly if more physicians and physician practices and providers had access to the best technology so they wouldn't have to do things with old-fashioned paper, probably speed things up for them. But having that infrastructure costs money as well. And so chances are these particular providers, small in rural areas, probably don't have the monies to buy the latest technology easily. So it's no easy fix, but certainly the efficiencies that can be extracted by being able to move towards electronic record keeping and so forth would be helpful. Maybe there's some way we could just support the efforts of some of those providers to get themselves boosted up. But again, that's where we're probably gonna have to come to you to see if we can find the support.
Understood. And I guess going forward, and I'm sure, and you've shown this, and I appreciate this, but just to be frank, have you on the record, will HHS commit to working with me and my office and my constituents on solutions to fix Medicare reimbursement rates?
Absolutely, because my daughter and her husband live in Salinas, so you got my word that either you're going to tell me about it or she and her husband are going to tell me about it. And by the way, he's a physician.
Oh, you got it. You understand well. Well, thank you, Mr. Secretary. I appreciate that. I yield back, and thanks for your time today.
Thank you.
Thank you, Secretary Becerra, for appearing before us today and going through the entire committee, even though we had to break for votes. We appreciate that. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. And with that, the committee stands adjourned.